Good evening, everyone. Happy Republic Day to all of you. On behalf of Adley Oncology, it's indeed a great pleasure to welcome Chief Guest, Dr. Renu Saxena, Speaker, Dr. David Kuter. Doctor will be speaking on diagnosis and treatment of autoimmune hemolytic anemia. A very warm welcome to all the discussants and all the attendees for sparing your valuable time for this academic feast. I have a couple of slides to present you regarding the current developments in Adley Oncology. Your wish can become a reality now. Long-term survival is possible in relapsed AML patients with azacitidine oral. I am very glad to introduce you MDSO, that is azacitidine tablets 300 mg and 200 mg. Now it is available at very economical price for all the Indian patients. Not only that, in our philanthropic endeavor, we'll ensure that all the non-affordable patients get the therapy benefit with our free drug support program. The second molecule which we'll be launching is carfilzomib. We'll be launching carfilzomib in the month of February. To commence the event now, I would like to invite Dr. B Agarwal, sir, please. Thank you so very much.
So hi, good evening to one and all. Thank you, Mr. Ashutosh. Welcome to this webinar. Today, we once again, Best of ASH, which began 24th of Jan and will go up to 30th of Jan. Happy Republic Day to all of you on my behalf as well. Day 3 of this webinar, brought to you by Mumbai Hematology Group, managed by Mice Ideas. The first lecture, as stated by Mr. Ashutosh, is on diagnosis and treatment of autoimmune hemolytic anemia, delivered by none other than Dr. David Kuter, Professor of Medicine, Harvard Medical School, Director, Clinical Hematology, Mass General Hospital, Boston. He was with us previously as well during the series of webinars when he spoke masterly on his pet subject of ITP. This part of the webinar is supported by Adley. This will be followed by second lecture, which is on heparin-induced thrombocytopenia, popularly known as HIT. This will be delivered by Dr. Adam Cuker, who is Section Chief, Benign Hematology, Associated Professor of Medicine Pathology, Perelman School of Medicine, University of Pennsylvania, Philadelphia. And that part of the webinar is supported by Natco. I thank Mr. Ashutosh Shukla and the team from Adley, Mr. James Rajakumar and team from Natco, Mr. Rajesh Kalpesh and the team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. David Kuter from Boston, Dr. Adam Cuker from Pennsylvania, all our discussants who are themselves eminent hematologists, you participants for sparing your Wednesday, in fact, holiday evening. We have excellent discussions today, and these are listed here. Dr. Cecil Ross, Professor of Medicine, Head Hematology, St. John Medical College Hospital, Bangalore. Dr. Sharad Damodar, Clinical Director, Senior Consultant and Head Department of Hematology and Bone Marrow Transplant, Majumdar Shaw Medical Center, Narayan Health City, Bangalore. Dr. J.M. Kunga, Consultant, Professor and HOD of Hematology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Former Secretary, Delhi Society of Hematology and Vice President, ISHBT 2016-17. Dr. Mukul Agarwal, Assistant Professor, Department of Hematology, AIIMS, New Delhi. Dr. Samir Malinkari, Consultant Hematologist and Director, Blood and Marrow Transplant Unit, Dinanath Mangeshika Hospital, Pune. Dr. Riya Balikar, Hematologist, Hemato-Oncologist from Wockhardt Hospitals, Nagpur. Dr. Neeraj Siddharthan, Clinical Professor and HOD, Department of Clinical Hematology, Amrita Institute of Medical Sciences, Kochi. Dr. Subhaprakash Sanyal, Director, Hematology and Bone Marrow Transplant Services at Fortis Group of Hospitals, Mumbai. Dr. Deepanjan Haldar, Consultant Hematologist, Hemato-Oncologist and Bone Marrow Transplant Physician, Jupiter Hospital, Thane, Mumbai. Dr. Amit Khurana, Consultant Hematologist, Bone Marrow Transplant Physician, Surat. Dr. Dheeraj Bhattat, Consultant Internal Medicine and Hematology at Sir H.N. Reliance Foundation Hospital and Research Center, Girgaon, Mumbai. Dr. Abhishek Dudhatra, Hematologist and Bone Marrow Transplant Physician, HCG Cancer Center, Ahmedabad. And Dr. Aditi Jain, Assistant Professor, Vardhaman Mahavir Medical College and Safdarjung Hospital, VMMC and SJH, New Delhi. It's my privilege to introduce our chief guest of the day who is going to inaugurate this webinar. And I'm absolutely honored by her kind presence. There's none other than Dr. Renu Saxena. Very, very well known to everybody in the field of hematology in this country. At present, she is Director, Pathology and Lab Medicine, Head Hematopathology, Medanta, the Medicity, Gurugram. Formerly, as you are all aware, she was Professor and Head Department of Hematology at AIIMS, New Delhi for decades. She is Fellow of National Academy of Medical Sciences. She is recipient of various awards and prizes, just to list a few of them. Malti Sathe Oration Award by ISHTM, Professor Dinkar Chandra Memorial Oration Award by UP Chapter IAPM, BGRC Silver Jubilee Oration Award for Outstanding Research in the field of Hematology and Immunohematology by ICMR, Manorma Sapre Oration Award by ISHBT. Well, Dr. Saxena, we are really privileged and honored by your kind presence. And I request you to inaugurate our today's webinar and also give some words of wisdom to our junior colleagues.
Thank you very much, Dr. Agarwal. It's indeed a great pleasure and privilege for me to be able to speak to the young hematologists and the group that is collected here today. So we are again gathered here to hear the best of ASH. And at this point of time, I would just like to give a few messages for the young Buddhist internists or pathologists, and something for middle-level hematologists, and then something for the senior hematologists who are there in the audience. So to start with, for the youngsters who are just at the brink of their journey and they're trying to decide where to go further, I would like to just bring to their notice that I was in their state long time back as well. At that time, I didn't have so many choices after doing my MD pathology. Hematology was just a small part of pathology and a small part of medicine and pediatrics at that point of time. Since then, hematology has come a long way, and there have been departments of hematology which have been created, and it has actually come into being as a definite specialty. So for those of you who are wondering what they should go in for, hematology is a very lucrative branch to take, whether you are a clinician or whether you are a pathologist as per your background. Both options have super specializations and a lot of new things to offer. For the middle level hematologists, as you can see, hematology is advancing in a very fast manner, whether it be on the clinical side, where we have a lot of cellular therapies being very enticing, a lot of targeted therapy coming, whether it is on the lab side with the whole gamut of molecular tests and NGS. So with all these newer options coming, there is a lot to look forward to. Coming to the senior hematologists. So there is so much advancement going on all the sides that I think it is really a feast to listen to the latest advances that are happening and to see how much of those we can imbibe in our own country, in our own culture, in our own hospital settings. And our attempt should be to get as much of it as possible in our day-to-day patient care. One thing that I have noticed in hematology is that there is a very close interaction between the clinician and the lab pathologist. So I would urge all the hematologists to have a good backing with their lab, and vice versa for the lab people to have good clinical teams as well, because together clinicians and the lab pathologists make a team which takes hematology forward. And in this connection, the various CMEs that are being held and organized a lot by Dr. Agarwal and his whole team, I think these offer excellent sources for advancements in hematology to all of us. So with this, I wish you all the best of luck, and we look forward to hearing two excellent lectures today, both for benign hematology, which I would like to reassure to everyone is not any less important than malignant hematology. All the best for today's entire program.
Thank you so much, Dr. Renu Saxena, first of all, for sparing your valuable time on a holiday. You come and joined us for the love of hematology, and your message to all the three tiers of hematology was fantastic, to the junior colleagues and to the senior most. You are, loved by everybody in the field of hematology.
Thank you so much.
Teacher for excellence. I enjoyed visiting your center at AIMS multiple times, and you have been a perfect host as well those days.
Thank you so much.
And sooner or later, the pandemic will be over and we will have an opportunity to meet again.
Definitely. Yeah.
So now we move on to the first guest lecture of the day. And as was introduced to you, we have Dr. David Kuter already with us. Sir, welcome to this forum and good morning to you. He is Professor of Medicine, Harvard Medical School, Director Clinical Hematology, Mass General Hospital, Boston, USA. In this forum, he gave wonderful talks to us on ITP, and today he's going to cover the subject of autoimmune hemolytic anemia. So, sir, over to you.
Thank you. Let me share my screen with you in typical Zoom fashion. We all spend much of our lives on Zoom. So let me start up my machine here, but it's a pleasure to be with you. Thank you for asking me to talk to you again. May I presume you can see my slides? Discuss current, which I think are rather basic, and then I'll talk to you about new approaches for treating these conditions which we've participated in. So let me begin by a bit of history. It's always fun talking about where hematology starts because I don't yet know where hematology is going to end up, but autoimmune hemolysis has a long history. If one looks at this condition, what you see here is that back in 1871, there was a disease called paradoxical destruction of red cells that caused jaundice. This was published back in 1871, and the spherocyte was identified at that time. And then this lovely chap, Stephen McKenzie, started thinking about black urine that contained hemoglobin and thought that the kidneys were having vasoconstriction and destroying red cells. And he called this vasomotor neuritis, meaning that the kidneys were clamping down and causing people to have hemolytic anemia. And then we get to Wilson, who described the spleen as the major source for red cell destruction. And finally, the great hematologist, and I should say pathologist, Hayem, distinguished congenital from inherited hemolysis when he described acquired hemolytic anemia. And he called warm antibody hemolysis infectious splenomegalich icterus. And then finally, we get to Jonathan Landsteiner, who got the Nobel Prize in 1908, having described an antibody in the serum that causes red cell destruction. So this is a brief overview of the ancient history of autoimmune hemolytic anemia. So let's talk about the pathology of hemolysis. Let's talk about what happens to red cells. And the major criticism I'll make of my colleagues in North America is they send me patients for hemolytic anemia and don't actually prove the patient's hemolyzing. So let's talk about what hemolysis is, because that's the first step in actually making a diagnosis of any kind of hemolytic anemia. So you're all familiar with this. We make red cells in the bone marrow. The reticulocyte may spend 3 days making its process into the circulation. Red cells live for 120 days. At some stage, they die. When they die, they may release a little bit of LDH in the circulation, but not much. The hemoglobin, which is then degraded and retained by the body, is converted to heme. and heme is converted to bilirubin. If you do this excessively, as I'll show you in a minute, some free hemoglobin enters the circulation, is filtered by the kidneys, proximal tubular cells absorb the heme, and then you have a thing called urine hemosiderin. And if you have too much intravascular hemoglobin release, it binds to haptoglobin, and there are changes seen there. So what is hemolytic anemia? What's the definition? And to be honest with you, there's no classical definition other than this, which is a red cell survival under 120 days. The normal red cell turnover is 1% per day. Maximal turnover is 5% today. Remember that at least for North Americans, and I don't know what's true in India, is that 4 to 16% of adults in the United States have Gilbert's disorder, and they already have an elevated bilirubin. But what's interesting is if you have a little bit of hemolysis, this brings you to a doctor's attention much faster than if you don't have Gilbert syndrome. So Gilbert syndrome brings a lot of patients to us for hemolysis, whether it be massive or minor. And finally, remember that there are many compensatory mechanisms for making red cells, ranging from erythropoietin to a lot of other mechanisms. And our normal red cell production, as you all know, can be increased anywhere from 5 to 8-fold in a normal human physiology. So when we talk about hemolysis, we talk about accelerated red blood cell catabolism. What happens is the reticulocytes are processed much faster. They enter our circulation much more rapidly. That's the historically called the shift red cell. When you have destruction of red cells, the LDH rises. More hemoglobin is processed into heme and then into bilirubin. If this happens intravascularly, the hemoglobin then is cleared by the kidney, and you have a urine hemosiderin present in when you stain the urine sediment, or you have haptoglobin bind the hemoglobin and it's depressed. So when we think about hemolysis, there are many classic indicators or signs of hemolysis. They pertain to the increased reticulocyte count that may happen in response to hemolysis. They can be the increased LDH, the depressed haptoglobin, and increased bilirubin from heme metabolism. And if you have intravascular hemolysis, you can have positive urine hemosiderin, or you can have positive urine free hemoglobin, and these are seen pretty much only in patients who have intravascular hemolysis. So at the end of the day, there are many exceptions to these rules. In hemolytic anemia, the reticulocyte count or retic index may be low in a third of patients with warm autoimmune hemolytic anemia. That's because the antibody can bind to red cell precursors and also reticulocytes. So you can have a patient who's chewing up lots of red cells in the periphery. The retic count is very low because the antibody is attacking both the bone marrow and also the reticulocytes. Second of all, patients may have other deficiencies. Red cell production may be low due to immune inhibition of erythropoiesis. There may be nutritional deficits such as folate or iron deficiency. We see this a lot, despite the fact all Americans are obese. Many are folate or iron deficient for many reasons. And finally, patients with hemolysis may have other chronic illnesses, such as lupus, that may impair red cell production. Finally, and I would just emphasize this, there are many patients sent to me with a high bilirubin, low haptoglobin, and a high reticulocyte count who are not anemic. You can have a very well compensated hemolysis that occurs because we're very good at adapting to red cell production. So these are a list of many exceptions that pertain to our discussion about patients with hemolytic anemia. So at the end of the day, we are asked, well, how do you diagnose hemolytic anemia with all this confusing data you just showed us? And this is an area where I think that our pathology colleagues and us as hematologists ought to think more about better diagnostic criteria. But we have I'll show you a little later on a publication that we recently did about a year ago, creating new guidelines for identifying hemolytic anemia. But basically, they're based upon old data that says that we have an increased LDH and reduced haptoglobin. If this is present, this is 90% specific for the presence of hemolytic anemia. But if you have a normal LDH and a haptoglobin over 25 milligrams per deciliter, this is 92% sensitive for the absence of hemolysis. These are really old manuscripts. This is really old data. And I would say that at some stage, if you're interested, this is a nice topic to readdress as to how we can be more precise in our diagnosis of what hemolysis actually means. So we then have created a definition. This is the review article I mentioned to you, is in Blood Reviews. It's an attempt at the first definition of hemolysis by Uli Jaeger and the rest of us. We diagnosed hemolytic anemia as an anemia characterized by shortened red cell survival characterized by an LDH above the upper limits of normal and a haptoglobin below the lower limits of normal. This is a very generous definition, which I think is still used in most clinical studies and by most clinicians. So you all know that hemolysis occurs. There are many interesting diseases that cause hemolytic anemia. Some are intrinsic to the red cell itself. There are membrane or cytoskeletal abnormalities that give you hereditary spherocytosis. This is reasonably common. There are enzyme defects. G6PD deficiency, as you know, affects about 400 million people worldwide. Pyruvate kinase deficiency, about 30,000 people worldwide. Then we have the ubiquitous problems of thalassemia and sickle cell disease, a component of which is indeed hemolysis. So these are problems that are intrinsic to the red cell. The other diseases are extrinsic to the red cell. There are non-immune things like artificial heart valves that can chew up red cells. The diseases DIC, TTP, hemolytic uremic syndrome, infections such as malaria that you know well, and in my part of the world, babesiosis can commonly cause this. Oxidative stress such as dapsone in someone who's got G6PD deficiency, but also in patients who don't have these deficiencies, you can have oxidative stress. Liver failure, which is common in my part of the world, can give you spur cell anemia. And then in a large spleen, hypersplenism is reasonably common for many disorders that can also shorten red cell survival. So these are the non-immune causes. And we're going to spend the rest of our time today, and we're going to get there, talking about immune causes of hemolytic anemia. And these are referred to as autoimmune hemolytic anemia. There is a cold antibody type of autoimmune hemolytic anemia. This is referred to as cold agglutinin disease, which is usually not characterized by any definable lymphoma being present. And then we tend to also think about cold agglutinin syndrome, which is a cold agglutinin hemolysis that occurs in the context of lymphoma, usually well-identified lymphoma. Then we have warm antibodies, which cause warm antibody autoimmune hemolytic anemia, and I'll talk about that. And then we have mixed disorders where some people have both. And in general, patients who have cold agglutinin problems have a significant amount of intravascular hemolysis. Those with warm antibody have extravascular hemolysis. But to be honest with you, both of these conditions, cold antibody disease and warm antibody disease, can have both intravascular and extravascular hemolysis. For example, as I'll describe in a minute, if you have a lot of antibody that's warm antibody, IgG on your red cell, you can have extravascular hemolysis, but you can also fix complement and have intravascular hemolysis. Equally important is cold antibody disease, which you classically think about as intravascular hemolysis. Indeed, 80% of the hemolysis is extravascular in the liver. And we'll come back to these topics in a few minutes, but this is the overview of what I want to talk about. Now, what's nice about hematology, going back to the excitement that Dr. Saxena and others have so far addressed today, is the fact that it's got beautiful morphology. If you're like looking at blood under the microscope, this is a fun area to be in. And I'm just going to take you through a couple of things. If I was with you in person, I'd quiz the audience as to what's seen here. But what you see here are lots of spherocytes, these smaller red cells, which have a lot of hemoglobin in them. They lack their central pallor. This is a patient with hereditary spherocytosis. The next is a patient who's got these very funny red cells. It's as if someone took a bite out of the red cell. These are called bite cells or blister cells, and these are what are commonly seen in patients who have G6PD deficiency and who have hemolyzed. This, I think you can all recognize as a sickle cell disease seen in patients with sickle cell disease, and we take care of a large population of these patients. Another slide is this, and I would love to quiz the audience here, but you can see lots of schistocytes, but you also see lots of platelets. So this tells you this is probably not someone with TTP or hemolytic uremic syndrome. Rather, because there are platelets present, this person probably has a prostatic heart valve, which is indeed the case. This patient had a very bad heart valve and was hemolyzing red cells like crazy and had an LDH, which was several thousand-fold increased. So this is a defective prostatic valve. In contradistinction is a patient who's got typical TTP. We have these beautiful schistocytes here. We refer to this as a helmet cell. Again, hematologists have very, very imaginative ideas of what blood cells look like. This is almost like a Pac-Man for those of you that are old like me and know what the old game was about Pac-Man. But this is the patient with no platelets and has schistocytes, and this is TTP. Could also be hemolytic uremic syndrome. Then you can all identify this red cell with this lovely malarial parasite in it. This is something we rarely see in the United States, particularly in the Northeast. But we then have another disease which is common in the United States, and this is what we see in August and September in our patients who come from the beach. These are patients who have babesiosis, and these are called Maltese crosses in the red cell. These are the parasites. This is two parasites in the cell here, one here. These are the babesia that are seen in this particular disease. And this gives in Boston and the Northeast, in August to September and October, we see plenty of patients who have this as a form of hemolysis. Then you can all recognize these beautiful cells here. These are what are called spur cells. Spur cells have sharp spikes on like this. This is a patient who's got hepatic failure. These are spur cells. Spur cell anemia is because the lecithin cholesterol acyl transferase, which is defective in the liver, makes these cells become quite heavy with cholesterol. They become very rigid. These were called lardaceous cells by Virchow back in the 1890s. And this is a spur cell anemia. Finally, we have things that we'll talk more about. These are clusters of red cells seen in a blood smear. This is a patient with a classic cold agglutinin or cold antibody. And so this is red cell aggregation right here. And then finally, we have another topic we'll talk about. This is a patient who's got plenty of reticulocytes, these polychromatophilic red cells here and here and here and here and here. High retic count, but also presence of spherocytes like this cell, this cell, this cell, and this cell. And this is a patient, as we'll talk about, who has spherocytes due to warm antibody autoimmune hemolytic anemia. So that's my overview of this class of diseases. Let me take one more digression and go on to the clinical laboratory of this, which is always fun to talk about, and that's the diagnostic test. And again, I apologize if this is all basic for you, but to be honest with you, when I talk to North American audiences that are full of hem-onc docs, there's a big question mark. They couldn't identify a Coombs test from a syphilis test, to be honest with you, but that's a joke. Don't quote me too much on this. But basically, the diagnostic tests in the hemolytic anemia date back to an old friend of mine, and he was a neighbor of mine when I lived in Oxford many years ago. This is a Professor Robin Coombs. This is a very youthful picture back from the 1950s from him. And he invented a test which you're all familiar with, which is referred to as the Coombs test, or more properly, the direct antiglobulin test. These are red cells with antibodies on them. And he actually made a reagent, he made a reagent in animals. This is back in 1948, where he injected human IgG, which had recently been purified by Porter and others at Oxford. He injected the antibody into rabbits and sheep, and he made antibodies against human IgG, which is called the Coombs reagent. He then added this to the red cells, and they agglutinated. And this was called a positive Coombs test, meaning that the red cells contain antibody on their surface. And then he did another clever test. He realized that you could take the red cells and sort of knock off the antibody on the red cells, and that gave you what's called an eluate right here. He could then take the eluate and incubate it with different types of other red cells from other people and ask whether this antibody bound to one type of red cells or a wide range of red cells. And he did the Coombs test on these as well and showed that the eluate either bound to one red cell type or many red cell types, distinguishing an alloantibody from an autoantibody. And again, I'm making this more basic than it probably should be, but basically, this is the results from a standard DAT test. If you have only complement, as we'll talk about, that's pretty much either an immune complex disorder or cold agglutinin disease. If you have IgG that's specific, that's an alloimmune process, usually from prior sensitizations by transfusion or pregnancy. But if you have IgG and the eluate binds to all red cells, that's a warm autoimmune hemolytic anemia. And sometimes if the antibody binds a lot to the red cells, it can fix complement. And you also see this in warm antibody hemolytic anemia. So this is the simplistic version of Coombs testing in patients with hemolysis. I should also mention, and this is a complexity we can talk about later if people have questions, about 20% of patients who have autoimmune hemolytic anemia clinically have a negative Coombs test. And we'll come back to that in a few seconds. So the punchline here, the bottom line here, after this long introduction about autoimmune hemolysis is, how do you know if it's an autoimmune hemolytic anemia? You have evidence of hemolysis, which is key. Never forget proving that, because otherwise the rest is irrelevant. You have a positive Coombs test. And thirdly, you have antibodies of two types. One is a warm antibody, which is 80% of the population. This is an IgG antibody that reacts to protein antigens and red cells at core body temperature. And then you have about 20% of patients have a cold antibody. This is IgM that reacts with polysaccharide antigens and red cell surfaces. This usually occurs at temperatures below the core body temperature, but can also happen at normal body temperature. So this is the definition that we have published in our guidelines last year for the definition of autoimmune hemolytic anemia of the two types: warm autoantibody and cold autoantibody. So let's now focus on warm autoimmune hemolytic anemia. This is a reasonably common condition. And I'm going to talk to you about the characters that go into this process. The first is the antibody. The antibody is invariably an IgG antibody with very rare exceptions. This is a polyclonal antibody, even in patients who have, for example, CLL, which is a clonal disease. This is a polyclonal antibody. It sometimes fixes complement. If it does, the disease is often worse, and it's temperature independent. This is a very high affinity antibody that binds to red cells with a binding affinity of 10 to the minus 14. It's a very avid binding. It binds to specific antigens. The antigens are interesting. They are of two types. They are the Rh proteins, of which there are about 40,000 per red cell. These are the antigens you all know from red cell typing. They are fixed to the cytoskeleton. The antigens are not dense enough on the red cell membrane to fix complement. In contrast is glycophorin. Glycophorin proteins, A, B, C, and D, there are about 800,000 of these proteins per red cell. They're fixed to the red cell, and they're fixed in a structure that they easily can activate complement. So here's a picture. Here's the Rh protein here. It's a transmembrane protein, a quite interesting protein with many transmembrane loops. Then we have glycophorins A, B, C, and D here that are all highly glycosylated and on the surface of red cells. And these are the major antigens against which red cells have antibodies be made in warm autoimmune hemolytic anemia. So what's the process? Again, this is a very simple version of this. Here's a red cell. Antibodies bind to with high affinity with their antigen combining regions here. They alter the Fc portion of the antibody. This binds to Fc gamma R3 receptors on macrophages, where they are then internalized and destroyed. And this macrophage resides primarily in the spleen, where the splenic macrophages will chew up the red cells and either destroy them completely or produce spherocytes. Occasionally, if there's a high antigen density here or an antibody that can be cross-linked, complement may be added to the red cell. And if C3 is added to the red cell, these are now opsonized and shuttled to the Kupffer cells on macrophages in the liver. Remember, the liver is about a 1/5 to 1/10 of the liver is macrophages or Kupffer cells. And occasionally, and again, I've got several patients where this is a characteristic of the disease. Some patients actually have such a high amount of complement binding, they actually can make the membrane attack complex C9 be present. And you can occasionally, about 1 in 50 patients with warm antibody disease, fixes so much complement that you can actually have C9 activation and have hemolytic anemia that's intravascular. So most of warm antibody is extravascular. Maybe 1 in 50, 1 in 20 is going to have some intravascular hemolysis as well. These events by antibody chewing away at the membrane give you spherocytes, as shown here. And this may pay for us to take a brief digression. And I don't know if any of you have actually taken a walk through the spleen, but the spleen is one of the neatest organs we don't talk about as hematologists. It's got a structure which has been studied for 3,000 years, but it's a nifty organ. And basically, here's the spleen. Blood enters via the artery. It then sort of diffuses into the parenchyma of the spleen, and then it's got to get back into the venous circulation and get back to your heart. And this is where all the processing of antigens, the processing of red cells occurs in the splenic space. And this is a lovely scanning EM that shows the cords of Billroth. And here's the parenchyma of the spleen. Here are all the cells here. Here's some macrophages. And then the red cell that's been percolated into the splenic area here has to get back into the sinus of the spleen. It's got to get through it. And what you see here is an endothelium, which has got all these holes in. So the red cell's trying to make its way from the artery into the vein. It's got to pass through this lovely architecture here where macrophages are going to recognize any antigen or complement surface because the red cells are opsonized. Then the red cells got to escape back through this very fun endothelium. And here's a picture of the endothelium from the inside of the sinuses right here. This is the inside of that blood vessel. Red cells have got to get back through these holes here. This is a challenge. It's got to be a deformable red cell. It's got to be able to wiggle through this. And this is where a lot of red cell destruction occurs. But this is a lovely picture, which I'd love to talk more to you about. But this is a neat organ that does a lot more than we think it does in hematology. So the definition, going back to the statement of fact here, warm autoimmune hematemia is defined as having evidence of hemolysis, an IgG antibody that reacts to protein antigens on red cells at core body temperature. This is a characteristic warm antibody with a positive Coombs test for IgG plus or minus complement, and it has a characteristic blood smear. And you will say, well, gee, why do we add the blood smear here? I'll be honest with you, I actually have more help. It helps me more sometimes to look at the blood smear in patients with hemolysis than it does to actually look at the laboratory tests that come from those patients. So what causes warm autoimmune hemochromia? And I'm going to talk to you primarily about chronic disease, not about acute events that happen after a viral infection and disappear in a couple of weeks. About a little under half of patients who have warm antibody hemolysis have no identifiable cause. About a quarter will have an underlying lymphoproliferative disease. And you all know that this is very common in CLL patients. About 11% of CLL patients will have a warm antibody hemolysis. May not be very bad. And this is actually exacerbated as we used to do when we gave people fludarabine as a single drug many decades ago. Immune disorders like the ones I primarily take care of, like CVID or lupus or ITP, account for about 25% of the rest of the hemoleucemias. And then there's a chronic viral infections can do this, such as EBV or CMV, and some drugs. And the drugs I'm not going to talk about all. That's a totally different discussion. But many of the gray-haired hematologists on this call, primarily me, remember a drug called procainamide, which caused hemolysis in almost every patient who got the drug many years ago. It was an antiarrhythmic. So how do you treat warm antibody hemochromia? I'm going to take you through some of the standard therapies, then digress and talk about some really nifty new stuff that's being done. Warm antibody hemolysis, the main therapies are to try to reduce the antibody, and the mainstay of all these patients, as all of you know, is corticosteroids. It works incredibly well, but if you're on it for a long period of time, it's incredibly toxic. So the mainstay of therapy is most patients respond to corticosteroids. You can sometimes replace corticosteroids with azathioprine, cyclophosphamide, cyclosporin, or mycophenolate, but usually after the patient is given corticosteroids, you wean them, you then say, well, the disease comes back, and rituximab works. And rituximab works very well in this condition, oftentimes at low doses. There's a complete remission rate of about 60% with rituximab, and that's based upon two studies, which I'll show you next. This is a study which is a bit old. It shows rituximab added to corticosteroids. This is 64 patients. Half got corticosteroids alone. The other half got corticosteroids plus rituximab at the standard Western dose of 375 milligrams per meter squared. There were no safety issues. And basically adding rituximab increased the CR rate enormously, as it did the partial remission rate, and that's shown better on the next slide. If you look at 3 months, the combined CR and PR rate were no different without rituximab or with rituximab, but by 6 months, the CR rate with rituximab was much higher at 60%. The combined CR plus PR rate was almost 80%, and at 12 months, the complete remission rate with Rituxan was 75%. And this lasted for oftentimes 1 to 5 years. And this is the relapse-free survival. These are the rituximab patients, we're out at 2 years here with a very modest relapse rate. This study has been recently published again at year 8, and the response rate at year 8 is down here at about 55 or 60%, sort of like the response rates you get with the ITP patients. Sort of not like the ITP response rate you get with rituximab. A second study done by my dear friend Marc Michel in France was published recently. It's actually a very small study, 2 doses of rituximab at low dose versus placebo. So this is a placebo-controlled study. Placebo means standard of care or steroids. The overall response rate, rituximab was 75% response rate, with most patients having a complete remission. The placebo patients had a modest response rate with corticosteroids alone. And this is the Kaplan-Meier analysis here. Rituximab provided a relapse-free survival for about 2 years, and well over half the patients got rituximab. Placebo patients, which means corticosteroids, they didn't do too well. Again, the p-value here is 0.023. So again, the algorithm for treating warm antibody hemolysis for most of us is corticosteroids. Sometimes we switch them to mycophenolate, which may hold some patients, but most patients end up getting rituximab. Other therapies that can be given are danazol, dapsone, and Campath. I would probably avoid Campath. It's a bit too toxic for this disease for most patients. Splenectomy works. So the other option, once you've failed corticosteroids or rituximab, is to do splenectomy. This is pretty much our algorithm, and this is what was proposed by the guidelines a year ago. Sometimes we can avoid splenectomy in some patients by giving mycophenolate, but splenectomy works quite well, and it's commonly done. IVIG in the emergency case can be given. It's got about a 40% response rate, doesn't last for very long. There is old literature on vincristine, which I haven't done in years, but there is a response rate in some patients. When you have patients with warm antibody hemolysis, this is a frustrating disorder to take care of for many of us, including me. You often need to have red cell transfusions, a backup, and many of these patients end up being transfused a lot for many years. And finally, it's important also to recognize that some patients do reasonably well, are a little bit anemic, have a compensated destruction and not an appropriate production rate. And using erythropoietin, just as you use thrombopoietin ITP, the use of erythropoietin in warm antibody hemolysis may increase the red cell count in patients whose reticulocyte counts aren't terribly high. But these are the standard current therapies, and the standard algorithm is corticosteroids. If you fail that, then you could try mycophenolate, but usually go to rituximab. If you fail rituximab, then we would often go back to mycophenolate or prednisone, but usually most patients end up having a splenectomy. So to summarize, here's the clinical truth, and I think many of the more experienced clinicians in our audience today might agree. Most patients respond to corticosteroids, but that response is rarely maintained off steroids. Splenectomy works, but many patients want to put it off or refuse it. Rituximab works really well with response rates of 70–80%. If you respond once, you can oftentimes respond a second time. There is a literature that's emerging that azathioprine or mycophenolate may be used to avoid steroids and avoid splenectomy, but it's a drug you can use. This is a frustrating disorder, unlike ITP, and many patients remain on corticosteroids for years. So there's what's called unmet medical need for new therapies. And there are a lot of new areas. And here's where I'm going to talk to you about a few things that were presented at ASH. I'll come to that in a few minutes, but I want to mention some new areas since one will be published in a couple of days. You'll be the first to see it probably. So there are things we can do in warm antibody hemolysis. We can use inhibitors of what's called the immunoproteasome. The basic proteasome, as you'll know, is inhibited by bortezomib, and you can use bortezomib in warm antibody hemolysis. But there is a drug called Kezar, this is his research name, 616, which is being studied in warm antibody hemolysis. There is no data on this yet. The study is underway. You can also inhibit the neonatal Fc receptor. Again, this is a study which is being started, as I'll describe to you later on. It hasn't got any data yet, but you can also use the neonatal Fc receptor inhibition. But what's happening right now are two major studies. One was Syk kinase inhibition, and one with Bruton kinase inhibition, where they turn off phagocytosis. So this technique is meant to turn off the antibody production. This is meant to make the antibody disappear from your circulation like plasmapheresis. but this is meant to block phagocytosis. And so let me show you a cartoon version of phagocytosis. So here's the membrane of the macrophage. Here's the Fc gamma R3 receptor, and here's a beautiful red cell. An antibody comes along, binds the red cell, forms a red cell antibody complex. This then will bind to the Fc gamma R3 receptors, and then this activates a whole signal transduction pathway in macrophages, which is dependent upon Syk kinase and Bruton kinase. And when this is activated, then the red cell gets internalized and it's destroyed. This is classic extravascular hemolysis. So we know that there are inhibitors of Syk kinase, one of which is a drug called fostamatinib or Tavalisse, which I don't think is approved yet for ITP in India, but is approved in other countries for ITP. So we have a drug that paralyzes the Syk kinase and can turn off macrophage. And we do have drugs, which I won't have time to talk about, and maybe one of the other speakers will mention our abstract at ASH this year, but we have a drug that will turn off Bruton kinase as well, that may also work in warm antibody hemolysis. So let's talk about Syk kinase inhibition. We did a study a number of years ago in mice. You can take mice, they have a normal hemoglobin or normal red cell count. We can give them an antibody against red cells, they become anemic. We can inject them with saline, doesn't make any better. But if you give them a precursor of fostamatinib called R788, you can increase the red cell count and turn off the hemolysis. So this is the preclinical data that fostamatinib works in turning off hemolysis. So we've done a study. It's been completed. It's going to be published any day now. And we looked at patients who had hemolytic anemia, warm antibody type, hemoglobin's under 10. We gave them this drug and we asked, did the hemoglobin rise over 10? And did it increase by 2 grams over baseline? This is a very simple study design. You give patients the drug for 24 weeks at different doses and ask what happened. There is no control group here. And here's the data. This will be published very soon in a medical journal. And basically, 11 patients responded, 13 patients didn't. The non-responders are shown here. They maintain a stable hemoglobin, usually on steroids. Those that got the fostamatinib had their hemoglobin rise almost to normal. And if you ask, well, how much did the hemoglobin rise? The hemoglobin rise by more than 2 grams and was maintained out here for well over a year in those who were on active drug. Some of the placebo patients did respond by rising by 1 gram, but it was not considered a response per our study definition. So this study has now been concluded and will be published in a couple of days. This brings me into my first ASH abstract, which simply says to you that there's a phase 3 study of 90 patients randomized to fostamatinib or placebo for 24 weeks. This study has just completed enrollment, and you'll hear the data as to what worked, fostamatinib or placebo, in about a year. But this study is now fully enrolled, and we're following the patients on this study. So let's switch gears. Let's talk about cold autoimmune hemolytic anemia. This may not be a disease that's commonly seen in a warm country such as most parts of India, but I live in the Northeast United States, and this is a pretty common disease here, not just because it's cold, because people have air conditioning. It's hyper cold even in the summertime here in Boston. So as I said, there's two types of cold autoimmune hemolytic anemia. One is referred to as cold agglutinin disease, which I'll come to in a second, and the other is called cold agglutinin, and I've misspelled it here, syndrome, which I'll talk to you about as well. So let's talk about the characters that participate in cold agglutinin problems. The antibody is pretty neat. This is an interesting antibody. It's an IgM antibody. It's clonal or oligoclonal. As I'll describe, it does not react with antigen via the antigen combining sites in the antibody, but on another part of the antibody, and it binds by a very weak van der Waals or hydrogen binding, which is why it only works best in the cold. There is a concept called the thermal amplitude, meaning it works better at low temperatures than high temperatures because it's very weak binding affinity. But there are some patients who have a cold antibody, which is so powerful that it does work at body temperature. The IgM antibody can bridge 2 red cells, and more importantly, it fixes lots of complement. The antibodies have been purified and sequenced and cloned. They are IgM antibodies. They have a part of the heavy chain variable region, but not the antigen recognized area that recognizes two parts of the red cell, the little I and big I antigens, which I'll come to in a second. These antibodies are not mutated, but some are. These have been sequenced a lot, and similar antibodies are seen in lupus anticoagulant and antiphospholipid antibody disorders. So here's a crystal structure of the antibody. This is near the joining region of the antibody. These are called hydrophobic patches. They bind via very weak binds to the antigen, which are little I and big I antigens on red cells. They are not the antigen recognition areas here and here that are classic for warm antibodies that bind with high affinity. So if an IgG antibody binds to red cells, it binds at a binding affinity of 10 to the minus 14, whereas these cold antibodies bind with 10,000-fold less affinity and come off very fast. So what's unique about this? This is unlike other autoimmune or infectious diseases. This is a clonal IgM from clonal lymphocytes. So that's the antibody. We'll come back to that. The antigen is not as interesting as the red cell antigens. These are polysaccharide antigens on red cells. There are little I and big I, as we're taught in medical school. And not to bore you with biochemistry, this is the structure of the little I antigen. When a little I becomes a big I antigen, when it grows up and becomes an adult by having a second galactose added here. And these are the chemical structures of big I and little I antigens on the red cells. And this is one of the characteristics, which is probably not that important in cold agglutinin disease. So how does cold agglutinin phenomena work? Well, blood flows to your fingers, and in Boston right now, it's a minus 14 centigrade, and basically the antibody binds to red cells, it fixes complement. The red cell then returns to your central circulation, the red cell warms up, the antibody comes off, but the red cell has been decorated with complement. If the entire C9 attack complex is formed, you have intravascular hemolysis. If it's not formed and there's C3 coated red cells, then this goes to liver and spleen, and it's cleared by the liver and spleen. And as I said before, we're taught in medical school that this is the major form intravascular hemolysis. This is only partly true. Probably a third of hemolysis is intravascular, 2/3 is extravascular hemolysis in the liver, as I'll describe in a second. So we have an antibody-dependent binding, we have a hemolytic anemia, then we have another phenomenon, which I see a lot of in this time of the year. We have red cell agglutination problems called acrocyanosis. And this is a phenomenon I'll describe in a second. This is, I love cartoon pictures. This is from Sigvard Berntsen, and Dr. Berntsen in Norway has probably the world's largest collection of cold antibody diseases because he lives in a very cold country. But this is a red cell. IgM is bound to it. Complement C1 gets bound here. C3 gets added. You have red cells decorated C3b. If it's just C3b, they go to the liver, where Kupffer cells will remove the C3 bound red cells, or alternatively, C3b will be inactivated to C3d, and you'll have red cells that circulate here with C3d. But sometimes the whole attack complex is added, and you have red cell hemolysis. This clumping of red cells here causes acrocyanosis. And this is a patient of mine, it causes red cell clumping, as shown here in the test tube. And if you do what's called a bedside cold agglutinin test, you can actually show that here's the warm tube of blood and here's the clump of red cells here. But this clumping can also occur in your circulation. And what you see is patients like this patient of mine who's got an ischemic digit here and here, because she went skiing and the blood clumped in her fingers, and it's caused a small infarction of this finger here. You can actually have tissue damage here, or a loss of the distal extremities here, the distal parts of fingers here, from acrocyanosis. This can in some patients be as bad as the hemolysis and sometimes worse. So what's the cause of cold agglutinin disease? Well, I'm not going to talk about the transient disease, which is infectious. This is due to mycoplasma or mononucleosis. These occur, they are common in EBV infection. This is a different topic. I'm going to talk primarily in the remaining time here on this disease about the chronic diseases, and they fall into two categories. One is called primary or benign cold agglutinin disease, or this is a disease which does have a clonal lymphocyte population. And I'm not going to talk much about cold agglutinin syndrome, which is cold agglutination, which occurs in the context of lymphoma. The therapy for these is treat the lymphoma. The therapy for these, as we'll come to, is a little bit less clear. So I'm going to talk about primary cold agglutinin disease, which is the more common disease. This one is pretty much taken care of in most patients by treating the lymphoma. Now, primary cold agglutinin disease is not benign. It is a clonal IgM. There's an abnormal kappa lambda ratio 9% of the time. 76% have a very low grade lymphoma, sometimes a lymphoplasmacytic lymphoma. Others have CLL or marginal zone lymphoma. About 25% of patients are normal at the time you meet them, but most patients will evolve. And if you look hard enough, you will find a clonal lymphocyte population by flow in almost all patients. These patients rarely transform to an aggressive non-Hodgkin's lymphoma. Over 10 years in Dr. Berenson's experience, this happened in 3.5% of patients. So how do you treat this disease? Well, I'd like to send them all to the warmer parts of India because avoidance of cold can help, but the problem we face is we have air conditioning. And so in the old days, we sent patients to Florida, they did well, but now that Florida is colder than Boston in the summertime, we really have problems that there's not a solution. Folate and iron are necessary for these patients to keep up red cell production. Red cell transfusions are used commonly, but remember to use a blood warmer because you don't put cold blood into a cold agglutinin patient because it hemolyzes. Some patients can be managed by plasmapheresis. You can take out the IgM antibody by pheresis, and there are some patients who are managed by pheresis in October to see them through Christmas time. If you have a compensated hemolysis and want to compensate better, erythropoietin works. In prior decades, cyclophosphamide and chlorambucil worked. I would probably not use those these days. They're not very potent, but there are ways of treating the underlying disease which are quite good. They are rituximab with fludarabine, and finally rituximab with bendamustine. Clinical trials I'll describe in a second, and there are some novel agents. So rituximab, it's not a great drug in cold agglutinin disease, but it works. It gives you a partial remission well over half the time. It rarely gives you complete remission, but it's a benign therapy. Low doses work. And these patients are elderly. It's a very acceptable therapy. The next iteration was rituximab and fludarabine. Again, these are really small studies of 29 patients. We now have CR rates of 21% and PR rates of 76%. With a long duration of response. The problem with this approach is that the average age of these patients was 75, and there was grade 3 or 4 hematologic toxicity in many of them. Here's the Kaplan-Meier analysis of 22 patients who had a CR/PR. It lasts for 60 months, which isn't too bad for a reasonably benign therapy, reasonably aggressive therapy. The third and more recent approach is rituximab and bendamustine, which I think you're all familiar with, with CLL therapy. This is a study done looking at 4 cycles of 28 days each of rituximab, 375 milligrams per meter squared given in day 1 each month, and days 1 to 2 of bendamustine for 2 days at this dose. Complete remission rates of 40%, partial remission rates of 31%, and non-responders about 30%. This is a very successful therapy with much less side effects than when you use fludarabine. So 91% of responders were still doing well at 3 years. So rituximab or bendamustine is currently the major therapy if you're using chemotherapy for cold agglutinin disease in patients who have not had a good response with rituximab. I should emphasize that rituximab rarely makes the acrocyanosis go away, but this form of chemotherapy commonly can make the acrocyanosis go away. So where does that leave us? It leaves us to make a statement, which is that other classic therapies don't work. Corticosteroids rarely works. Splenectomy never works. IVIG rarely works. So what's in the pipeline? What's in the pipeline again are immunoproteasome inhibitors, and the keys are 616 study is not started up yet. You all know about sutimlimab. So you all know about eculizumab, which is a C5 inhibitor. There's a new C1 inhibitor, which we have published on extensively that can also be used here. There's a fourth agent, which I can't talk about yet, but there's another drug that will make IgM disappear from your body that we'll talk about maybe in a future discussion. So this is a topic which I hate to present to an audience because it brings up another pathway that's oftentimes confusing. This is the complement pathway. To make a long story short, you fix antibody to red cell, C1 gets activated, C3 gets generated, C3 gets put on red cells, they get eaten up by the spleen, get eaten up by the liver. If you then make C5 and then C9, you lyse cells. C5 inhibitor is Solaris eculizumab. There are C3 inhibitors. Pegcetacoplan is the more recent one for PNH, and there's a new C1 inhibitor and an old C1 inhibitor called C1 esterase inhibitor, which have been studied. This is a study that was a very small study by Alex Roth with eculizumab. This is 13 patients. He showed that you could drop the LGH a little bit. You could make the bilirubin drop a little bit. You could make the hemoglobin rise a little bit, but this was not terribly good because it only affected C5. It did not affect C3, and this is the major reason for failure of this drug in cold agglutinin disease. This is the LGH. It dropped, but it didn't go to normal levels at all. Notice that the vertical axis here ends at 200, normal's down here. And this has led us to experiment with this disease a lot. And this is a new C1s inhibitor that we've published on recently called sutimlimab. It inhibits C1, and it basically turns off C1 entirely, preventing all the downstream effects. And going back to our cartoon of where things work, eculizumab inhibits C5 here, prevents C9, but in cold agglutinin disease, many red cells are full of C3. Apellis 2 or pegcetacoplan has not been studied yet formally in cold agglutinin disease. That may work at this step. That drug was recently approved, as you know, for PNH, but sutimlimab and others will inhibit C1 right here. And this is our study. We published this last summertime with cold agglutinin disease. Open label study, small number of patients, weekly doses of sutimlimab, no significant adverse events. Everybody improved. Hemoglobins rose by 2.3 grams by 3 weeks, but it did not affect the acrocyanosis. And here's the data. The hemoglobin goes from about 8.5 up to 12 on average. The bilirubins drop to normal range, and the fatigue score improves dramatically. And in so doing, we have inhibited the complement pathway. This is the C1 pathway shown here. We've inhibited with this drug, and C4, which is being consumed by the activation, goes back to normal. So this is a drug which is through the clinical trials, and the next ASH abstract is shown here. Excuse me. This is a phase 3 study comparing placebo to active sutimlimab. And it basically shows that if you have 24 weeks of placebo, your hemoglobin doesn't rise, but with sutimlimab you did. This is an ASH abstract that we presented a couple of weeks ago. Bilirubins drop in sutimlimab, remain elevated in placebo, and you'll see the full data, but there's a 73% response rate with sutimlimab and only 15% with standard care. So to summarize this entire talk, and I'm going to give you a 1-minute summary and then spend 3 minutes on ASH abstracts and then tell you about the space station, okay? The first thing about hemolysis is prove hemolysis first, do a Coombs test second, and look at the smear to help categorize it. If it's a warm autoimmune hemolytic steroids, rituximab, and splenectomy work really well. Novel therapies, fostamatinib, neonatal FC inhibitors, and Bruton kinase inhibitors are being studied. Cold agglutinin hemolytic anemia, if it's cold agglutinin disease, which is the non-lymphomas variety, rituximab and bendamustine work. C1 inhibition also will become available shortly. If you have cold agglutinin syndrome, meaning lymphoma, treat the lymphoma. If that doesn't work, use rituximab and bendamustine, or use a C1s inhibitor. So let me digress for 3 more minutes, and then I hope you will bear with me. What was new at ASH and hemolysis? Wasn't much. It was fun to talk to my colleagues, but basically The statement of fact is here that there are probably 5 abstracts that bear a brief comment. The first is that if you have autoimmune hemolytic anemia and live in Denmark and France, there is an increased risk of stroke in these patients. And this is true that thrombotic events increase if you have warm antibody and cold antibody hemolysis, just like other hemolytic disease. The hazard ratio is about 2-fold increased if you have a hemolytic anemia. Second of all, from this large French observational study, they found that patients who have autoimmune hemolytic anemia and are admitted to the ICU do reasonably well. The mortality rate is about 13%, but in severe warm antibody and cold agglutinin disease, there's a 30% fatality rate in 1 year. So this is not a benign disease in terms of its effect upon longevity. The third abstract that bears some comment is, what about in typical AIDS, this typical COVID-19 era, what if a patient with an autoimmune hemolytic anemia, cold or warm, gets a vaccination? And as many of you know, I've published data that the SARS-CoV-2 vaccination may drop your platelet count in ITP. Well, about 10% of patients who have cold or warm antibody hemolysis will drop their red cell count, but it only drops severely in about 5% of patients. It rarely required therapy, and if it did require therapy, it was usually steroids, and the counts came back up again. The fourth abstract, on 11 patients only, was entitled "The Effect of Cyclosporin." This shows that if you give cyclosporin to warm antibody hemolysis patients, there is a modest CR rate of about 25%, a PR rate of about 15%. So about 40% of patients respond to cyclosporin based upon this Italian study. Finally, and this is a call out to new therapies, this is a study looking at a drug called nipocalimab. This is a neonatal FcRn inhibitor. This is a study which is just being started in this disease. I don't think patients have been enrolled yet, but this drug has been proven very effective in myasthenia gravis to decrease the pathologic antibody. And the expectation is that this drug will decrease the pathologic antibody in warm antibody hemolysis. I've already told you about this abstract, and I won't repeat it a second time. So let me take you to my last teaser here. I gave you an assignment a few minutes ago, maybe an hour ago. And that's, why do astronauts become anemic? And this is a study was published a week ago, maybe 8 days ago. The hemoglobins before you go up in the space station, this is 22 astronauts were normal. And then you go in the space station, you come back. We can't draw blood easily in the space station, and you're anemic. This has been shown for years. When you're back on Earth, your blood counts then go back to normal. So the question is, why does the hemoglobin drop? Not a huge amount, but why does it drop? And this is both men and women on the space station. They are up here for about between 6 and 12 months. And basically, this is measuring, and this is the one heme test you can do, sorry, in the space station. I don't know how Fidel Castro did it. You can measure carbon monoxide. Do a breath test on a space station, your carbon monoxide levels rise. Get back to Earth, they go back to normal. When you hemolyze, heme gets converted to biliverdin and bilirubin. This is a question I give to most of my medical students. What process in the body makes carbon monoxide? It's heme metabolism. And basically, you can measure carbon monoxide as a measurement of hemolysis. These are sickle cell patients. As the bilirubin rises as a sign of hemolysis, the carbon monoxide level rises. So I use this lovely old 1930s technology in the space station to show that that hemolysis occurred during weightless exposure. Why this was happening, no one was clear, but this is a lovely example of old technique from 1930s being used in 2022 to look at a problem of hemolysis in astronauts. And on that, before my voice dies on me, I'll thank you for your kind attention and invitation to talk today. And I'm pleased to answer any questions you might have. Thank you.
Thank you, sir, for that beautiful talk, updating us also with ASH and this lovely space hemolysis. Thank you. We'll have some questions. Dr. Neeraj.
Thank you, sir, and thank you, Professor Kuter, for that excellent talk. I have two questions. One is in a patient who has already established to be having hemolysis, and if you do a Coombs test, and if you find a Coombs test negative or 1+ or 2+, and all other causes of hemolysis are negative, then how do you approach? Do you consider when the Coombs test is negative, and B, when it is 1+ but 2+, and other causes of hemolysis are negative?
Yeah. So like I say, sorry. So let me take that. You can let me finish the first part because my memory doesn't hold these things very well. So basically, if someone comes in with a typical Coombs negative hemolytic, what do I do? Well, first of all, how do I know it's hemolysis? Because I'm lacking the blood test that helps me a lot. To be honest with you, if someone comes in with a reduced hematocrit, high reticulocyte count, and has spherocytes on their peripheral blood smear, which is why I love looking at blood smears, even the Coombs test is negative, I'll regard that as a warm antibody and treat them with corticosteroids. And like an ITP, where the response to corticosteroids helps prove the diagnosis, if they respond to steroids, then I'll assume that's going to be a warm antibody hemolytic. If the patient has a 1+ or borderline Coombs test with IgG, I'll still regard that as a positive Coombs test and regard them as having a typical warm antibody hemolysis. It's the only problems we face are the ones that are truly Coombs negative. I think that's where pragmatism come into play here. Look at the blood smear. If there are spherocytes, if they respond to steroids, then I think you can presume that this is a warm antibody process. There are more sophisticated blood tests you can do. And let me digress for 30 seconds, if I may. If there are any blood bankers who I apologize for being oversimplistic, but it's not just IgG that causes warm antibody hemolysis. About 10% of patients have IgA. Most laboratories do not test for IgA on red cells. In the United States, there are reference labs we can send our bloods to, and our own hospital does this. We will then, if it's a typical negative Coombs test, no complement, no IgG, we'll test for IgA or send it to a reference lab looking for that. In addition, there are what are called super Coombs tests, which you may have read about. Most Coombs tests will detect up down to about 150 or 160 IgG molecules. There are more sensitive ways to look at aggregation. They may be helpful, but to me, if someone has a Coombs negative anemia, a Coombs negative hemolysis anemia, I will use the smear and available serology to make a tentative diagnosis, give them steroids. If they respond, I'm happy.
And the second scenario is a patient who already diagnosed to have autoimmune hemolytic anemia, and who is very good, doing good on a very low dose of steroids, probably 5 milligram of prednisolone, but Coombs test is still 4+. It doesn't come down. So how do you?
It's not going to come down. It may be up for decades. So many people who are in remission. Let's pretend we give someone steroids and they have a compensated hemolysis with a hemoglobin of 11 or so. We're tick count of 8%, doing well. They'll still have a positive Coombs test for years, but that the antibody, the presence of antibody doesn't necessarily predict hemolysis. And the classic example for those of you who have gray hair was procaine amide from 40 years ago. Everybody had a positive Coombs test, and very few people hemolyzed. So there is an offset that some patients, when you treat them, do well. They still have antibody, but they're well compensated.
So can we stop steroids in such patients? Do you stop steroids in such patients?
Well, again, I will always try to get people down to the lowest dose of steroids. And like in ITP patients, where I still accept low dose steroids, meaning 5 milligrams or less, as being acceptable. If I can get someone to 5 milligrams of prednisone and have a hemoglobin of 10, I will try to wean their prednisone lower. But if I'm not successful and they do fine at 5 milligrams, I'll just keep them on 5 milligrams.
Yeah.
But higher dose, unfortunately, most patients require higher doses of corticosteroids, and at that point, you want to go to other therapies, particularly rituximab.
Thank you very much.
Thank you. Samir?
Hi, good morning, sir. I have two questions. The first simple question is, do you perform your Coombs test using a gel card or manually?
Oh, we use an audit. We used to the gel card. We now have a new automated system. I can't remember which company sells it to us, but there are like 50 different Coombs tests. We have an automated system, which is a gel-based system.
Okay. The second question is, every now and then I come across patients who have acquired transfusion-dependent anemia, where there is no evidence of hemolysis. The Coombs test is negative. The retic count is normal to low. But if you do a bone marrow, you see complete maturation up to the late normoblasts, but the retics are low. And there's no dysplasia. And if you work up for do a FISH and karyotyping, the regular test for MDS, they tend to be negative. But many of these patients actually respond to steroids. So would you call these patients as, would you label them as autoimmune? And the other question is in such.
Yeah, I would label such, I think right now, as I said, we are not good with 20% of patients who indeed have autoimmune hemolytic anemia, warm antibody type, because they don't fit the characteristics I mentioned to you. And I would have said this before, but I didn't have enough time. In patients who have all of the attributes of hemolysis, but have a negative Coombs test and a lower tick count, I will do a bone marrow biopsy. If they have a very cellular marrow with lots of red cell production and don't have any signs of MDS, then I would, give them corticosteroids, and if they respond, I would define them based upon the steroid response as having an autoimmune process.
We know that MDS can lead to autoimmunity, and so how would you go for a next generation sequencing to look for the comprehensive mutation analysis for these patients, or a DNA microarray?
And to be honest with you, I think when you have a patient like the one you just posed with a negative Coombs test and chronic, those patients almost always get a bone marrow biopsy. We will do a full NGS panel to see if they have MDS. If it's someone over 70 or over 60, we'll do that for sure. If it's an 18-year-old person that comes in with bad hemolysis and responds to corticosteroids, we'll probably still do a bone marrow biopsy, but most of those patients will not have an underlying hematologic condition. Now, there are a lot of exceptions here. We are increasingly coming to realize, like in ITP, where maybe 1% of patients with ITP have a congenital disorder, in patients with apparent hemolytic anemia, they could have pyruvate kinase deficiency. They could have other enzyme deficiencies, which we can check. And there's now a battery of genetic tests for a hematology snapshot for hemolysis that one of the companies that has a drug available lets us do to screen for all these interesting structural defects in red cells, ranging from hereditary spherocytosis to a hereditary lymphocytosis to some of the pyruvate kinase deficiencies. Again, those are rare patients. But again, if you do a bone marrow biopsy in a young patient and there's a lot of erythroid hyperplasia, retic count's low, what you'll find, you put them on prednisone, the retic count will rise, which is a sign that you made the autoimmunity process less, and they'll respond. Steroid response is a good pragmatic approach to proving it's immune versus non-immune. You're right, some MDS patients have immune processes as well. They'll respond to steroids. That's the ambiguity of medicine, as you know.
Yes.
Thank you. Mukund?
Excuse me, sir.
Okay, Sharad?
Dr. David, wonderful talk. Just two queries from a therapeutic perspective relevant to our situation here. The utility of low dose rituximab, like we've got data in ITP, and what is your experience with cyclosporin? When we're really pushed, we kind of go to cyclosporin. So your thoughts on that?
Yeah, I cut those out of my talk. I knew you were going to ask those questions. So thank you for asking that question. First of all, you all know the story about how the dose of Rituxan got calculated. To do the initial studies, we were part of that. They took the amount of available drug and divided it by 180 patients. And that was the dose. So it's not based upon science. So I have no troubles low dose the Rituximab. I don't know what low dose is in India. In Britain, my friend Drew Provan will use 100 milligrams as a flat dose. My friends in France will use 1,000 milligrams times 2 is low dose. Again, I think anything that depletes your B cells, and 100 milligrams of Rituxan pretty much depletes your B cells, will probably work. And there is a study that in ITP that I think I can legally cite. Yeah, it will come out next week. Looking at low dose Rituxan ITP of 100 milligrams, and it seems to work quite well. So I think right now that's fine. Cyclosporin certainly is a good drug for almost all autoimmune disease. So I have no troubles cycling after corticosteroids, cyclosporin, low dose rituximab. I just can't give any data as to response rates. Now, this is where India can do some really good studies in this disease. I mean, you've got the patients, you've got the very smart doctors. I know you all, many of you very well. So, you know, I think that you could probably do a study whether low dose rituximab works.
Right. Thank you. Thank you.
But certainly these drugs play a role. And if you look at our guidelines that we wrote last year, and Uli Jaeger, J-A-G-R, is the author in Blood Reviews, we've put all these in our article. I don't think you have to spend a fortune to treat warm antibody hemolysis, but the main message is don't kill your patients with steroids.
Right.
Sure.
Right.
Dr. Mukul?
Thank you, sir. Sir, questions are two. One regarding to the diagnostic and one to the therapeutic. So regarding diagnostics, the British guidelines say about doing immune electrophoresis and immunofixation for almost all the patients. Plus, they also recommend about CT scan and bone marrow in many of the patients. So what are your thoughts about these two tests in particular?
Yeah. So you're talking about cold agglutinin disease, correct?
Overall, they say about autoimmune hemolytic anemia and do not differentiate between one.
Yeah. Again, I know. Again, the British guides have differed a fair amount from the ones we published in the Blood Reviews last year. So I would simply say that our standard of care for both sets of disorders is to do a flow cytometry looking for clonal lymphocytes in patients who have no symptoms. We will probably still do a CT scan looking for adenopathy. We don't do bone marrows in most patients that have warm antibody hemolysis if they have a diagnosis of some autoimmune condition like common variable immune deficiency or some other like lupus. That may be a flaw in our care. But people have cold agglutinin disease, we will invariably do a bone marrow biopsy. We will invariably do flow cytometry. We'll invariably do a serum protein electrophoresis looking for a clonal IgM population. For most warm antibody patients, we'll do flow, we'll do a CT scan. We don't often do bone marrows. That's just our practice. It may not be right, but that's what we do.
The second is about therapy related. So in your treatment algorithm, you said steroids, if not responding rituximab, and if not responding splenectomy. So what is your take on combining both steroids and rituximab upfront for most of the patient? There's a study you quoted, and what is the role of bortezomib in these cases?
What was the role? What was the last part of that question?
Bortezomib.
Okay.
Well,
yeah. So So what I'll say right now is that most patients respond to corticosteroids, and when you taper it, they lose that response. So I would say that your term of non-responder, I think most people respond to corticosteroids, most patients respond to rituximab, and most patients respond to splenectomy. So in terms of sequencing things, we will do corticosteroids first, wean the corticosteroids. If they relapse, then we'll oftentimes go to mycophenolate, but if that doesn't work, we'll then go to rituximab, and if that doesn't work, we'll go to splenectomy. The question is, like in ITP, where there's proof that rituximab upfront works better, and the one study I showed you rituximab works, I think there's no trouble with giving rituximab upfront. I think that we have a problem sometimes with patients not wanting to get a chemotherapy drug, at least in North America, as initial therapy. So in general, we will probably save rituximab for month 2 or 3, but I would see no problems with giving someone 100 milligrams of rituximab or some low dose at the time of diagnosis. Again, it depends upon your resources and how you want to sequence care. The study I cited to you that was published in 2013 did give patients corticosteroids and rituximab at the same time, and that arm had a very nice response rate. It's a question of whether you want to give Rituxan at the same time as the diagnosis or later. I will simply say there are small subsets of patients who, after a month or 2 on steroids, get all better and it's all gone. So I usually defer rituximab for a month or two before I make that commitment. But I would see nothing wrong with giving rituximab at day one.
The second question is bortezomib.
Oh, I'm sorry. Yes, I apologize. Yeah, it's like 15 years ago. I've got on my shelf up at my desk, I've got some initial vials of bortezomib because I helped develop it 15 years ago for myeloma. So it's nice having watched this drug evolve. We've used bortezomib a lot. There's a clinical trial starting up with that in a patient with a warm antibody hemolysis. I think it works very well. It works very well in TTP, ITP. It's a very expensive drug to get. And I think even in the United States, where we spend money like water, it's hard to get it approved for use. But yes, I've used it. Yes, people respond. Yes, it's in our guidelines, but it's not in the top. I would probably, if I had available use of it, I would probably use it before taking someone's spleen up.
Thank you. Dr. Dheeraj.
Yeah, good evening, Dr. David. Excellent talk. Actually, sorry, good morning. I just wanted to ask an extension of the previous two questions only. Rituximab, which we are using upfront because of we want the steroids to be minimally used. Is there any role after 1 to 5 years when we are losing the response to rituximab? Can we repeat the dose? Because people may agree for rituximab, but not for splenectomy. That would be very difficult to convince.
Yeah, so I think right now the data for rituximab in warm antibody hemolysis for both hemolytic anemias for warm antibody is terrific. For cold agglutinin disease, it's less robust. But I think right now almost all patients respond to rituximab with a good response. If it's short-lived, we'll usually not retreat them. But if it lasts for 2 or 3 years and they relapse, we'll retreat them again. We have been very reluctant to use rituximab in North America for anything recently because of the vaccination issues with COVID-19. So we have actually taken off our treatment algorithm, unless it's life and death, rituximab for treating warm antibody hemolysis or ITP. Obviously, if someone is not responding, I'd rather have them get rituximab than stay on steroids for the next 5 years, but we have been very judicious in using rituximab.
And any papers on repeating the dose of steroids and with good responses?
No, I mean, even the good studies I showed you had 24 patients in them. Our cold agglutinin study had 23 patients. So this is not an area that's got a large patient. The largest study in warm antibody hemolysis is the one we just finished with 93 patients in it. That'll be probably analyzed and published a year from now. So it's very hard to have data. It's very hard to have this be a data-driven discussion. I apologize for this, but the reason I've switched from ITP to hemolytic anemia is just for this very same reason. I'd like to, and what's neat about warm antibody and cold agglutinin disease is there are a lot more companies we've convinced to actually devote their resources to new techniques to focus on complement, to focus on inhibition of phagocytosis.
Thanks, Cecil.
Hi, that was good lecture, sir. I wanted to know what is if you have a patient who's got steroid refractory, splenectomy refractory, and immunosuppression refractory, and you want to give erythropoietin. What would be the regimen that you would give, and would you want to check the erythropoietin levels before you start erythropoietin?
Well, we've actually done that study. I took it out. One of the slides in my talk has got that there someplace. But we've done this and looked at EPO levels in dozens of ITP patients, dozens of warm antibody hemolysis patients, and it's always normal or low in those patients. It's rarely elevated above 5. It's never elevated above 500 million international units per mil. So almost all patients are eligible to get EPO. And I think the best place for erythropoietin is not in the patient who's desperately sick. They need to be transfused, but the patient who's living at a hemoglobin of 8 and has sort of compensation at a hemoglobin 8, you can often get their hemoglobins to 9 or 10, which makes them feel a lot better by giving an erythropoietin. The dose we pretty much used was going to be it comes in, I think I've talked to some of you at a lovely symposium in Mauritius 15 years ago on EPO, but basically EPO is used either at 40,000 units of epotent alpha weekly, or using darbepoetin alpha at a dose of 200 micrograms every fortnight.
Okay.
So those are the starting doses. Obviously, you can increase the darbepoetin alpha dose to 500 micrograms every 2 weeks, which is probably the maximal dose. And the epoetin alpha probably can be increased to 80,000 units a week, but if that doesn't work, I'd certainly stop.
Okay, thank you.
Dr. Kunger, unmute yourself. Unmute.
Hello, Dr. David. Excellent presentation, sir.
Thank you.
Regarding first question by Dr. Neeraj Siddharthan, I just want to convey there are several cases of Coombs false negative autoimmune hemolytic anemia, where we are strongly suspecting autoimmune hemolytic anemia, but they are Coombs negative. This is because of lesser number of molecules of autoantibodies per RBC. When they are lesser than 5, Coombs test can detect only if the autoantibodies are more than 500 molecules per red cell. And by gel card, we can diagnose the autoimmune hemolytic anemia if the autoantibody molecules are more than 200 IgG autoantibodies per RBC. While by flow cytometry, we can diagnose even when there are 30 to 40 molecules of autoantibodies, IgG autoantibodies per RBC, we can diagnose by flow cytometry. So sometimes because of lesser number of molecules of autoantibodies per RBC, we can miss the false negative Coombs test.
Yep, I totally agree. But I'd also add that maybe about 12% of patients in our hands have an IgA antibody as well that causes.
I have done a study in Ames and on the false negative on these Coombs test, and there were 15% of cases. My study is published in Index Journal. There were 15% of cases which were false negative by Coombs test as well as by gel card test, but they were positive by flow cytometry, and patient was having autoimmune hemolytic anemia.
Yeah, no, I totally agree. We don't commonly use flow cytometry in North America for this. Send me your paper. I'd love to look at it.
Okay.
For the reference.
Thank you.
Thank you.
Dr. Subhaprakash.
Sir, lovely presentation. Sir, I have one question. When the patient initially diagnosed with autoimmune hemolytic anemia, the hemolytic rate is very severe. Do you use any thromboprophylaxis for this patient in the upfront for 5-7 days when the patient?
Yeah, that's an excellent question. I will simply say that we don't, but we probably should. The data is there that says that these patients, like in the other hemolytic will have an increased rate of thrombosis, but we traditionally have not done that. That may be our mistake. If someone has a active lupus flare, for example, we will pretty much put them on a prophylactic drug. But I think right now, for most patients who don't have any active inflammation, we don't do that. Again, another good topic of study. I will simply tell you that if you measure D-dimers or what's called prothrombin fragment 1.2 in those patients, there is evidence for thrombin generation that occurs. And it's something that probably we ought to study more, just like we haven't studied it much in ITP. We should study it more and more in antibody hemolysis. There is, in our study with the cold agglutinin disease, we haven't published this yet, the one we published in the New England Journal of Medicine last summer, we did check D-dimers and prothrombin fragments. They were not elevated in most patients. But again,
so my second question: when you the patients who are not doing well on the steroid, rituximab refractory, so how you choose the third-line immunosuppressive therapy in your clinic, and what is your choice?
Yeah, well, again, it depends on how bad their anemia is. If they're on chronic transfusions, then we'll be more aggressive in recommending splenectomy. If they are requiring few transfusions or just living at a hemoglobin of 8, we will try other immunosuppressive drugs. And our favorite immunosuppressive drug, as I mentioned, is CellCept mycophenolate. We have in those patients that are not responding well, we've tried bortezomib. We have used in prior decades, we've used Campath, which I don't like, cyclosporin. The list of immunosuppressive drugs is all the ones you guys are all familiar with. The problem we face with this disease state is there's no great study to cite that says that they're going to have a high response rate. Anecdotally, 40% of patients will respond to cyclosporin. Anecdotally, 40% respond to mycophenolate. So, that's the kind of bad data you're going to get from people like me.
Thank you. Amit?
Thank you, Professor, for that wonderful lecture. Sir, I have a case at present with me of a warm autoimmune hemolytic anemia. Direct Coombs test is strongly positive with IgG and complement C3. To start with, before 5 years, he had the same episode of warm autoimmune hemolytic anemia. At that time, he had a gangrene in the index fingers. Right now, the autoimmune anemia is continued and is refractory to steroids, refractory to rituximab, refractory to MMF, refractory to cyclosporine. Ultrasound abdomen shows a hyposplenism with almost no spleen. So now how would you approach this case, sir? And bone marrow has been done. Bone marrow is absolutely normal with erythroid hyperplasia.
Yeah, I was afraid you were going to say that. So I was going to say do a bone marrow biopsy, but you've already done that. Yes. It sounds like he's got pretty bad disease, and I'm saying it with a smile on my face. I think you have many options, and there's no clear path. This patient has failed a wide variety of therapies. I would simply ask one question first: does the patient still respond to corticosteroids?
Only once. Then after he lost the response totally.
But have you tried steroids again?
Yeah, no response at all.
Okay, so and even if we're talking about significant doses of steroids.
Yeah, significant dose, and that he lost the response at 20 milligrams.
Recording stopped.
Yeah. Are the complement levels low? Have you checked complement levels in the circulation?
The complement levels are not low.
Okay.
The C3 and C4 are both elevated, sir.
Yeah. So basically, so basically, this patient has complement on the red cells. I mean, there may be a chance that a complement inhibitor might help this patient. That's incredibly expensive. It's hard to get. I don't have a clever answer. I think that I would still. I'd worry that this patient is having most of the hemolysis in the liver, so I would not be eager to take this person's spleen out. I would probably try, if this in the United States, I'd probably spend a lot of money and give them a complement inhibitor and see what happens. But that's not a cheap proposition anyplace.
Thank you, Amrita.
Yeah, I think other immunosuppressive agents. You could try bortezomib. If he has an antibody in his red cells, then you've got a pathologic target, whereas bortezomib may work. Okay, so that may be the relatively speaking, the cheapest next step.
Thank you, Amrita.
Yeah, thank you, sir. It was a wonderful talk, Dr. David. It was really very informative. My question partially answered by my Indian colleagues. And there is one query in my mind. Actually, like I work in a tertiary care health center, and we get a lot of cases where we happen to find autoimmune, these cold agglutinin disease, and we advise certain investigations. Many a times we are not even aware of the clinical details. But what my question is like, suppose a case is COVID positive, and we happen to get a cold agglutinin, feature suggestive of cold agglutination, and we incubate it at 37 degrees and then re-examine the complete blood counts and the peripheral smear. So as you said in your lecture that there is a high risk of ischemic stroke and all that, and already COVID is a high risk of thrombosis. So what all investigations would you like us to suggest in such cases? With the features.
I'll be honest with you. I think the problem we face with cold agglutinins is they're measured in a lot of clinical situations. They come back positive many times, and they're of no clinical merit most of the times. And give you an example, our hospital for 20 years has done a cold agglutinin test on every person about to have cardiac bypass. Almost none of those are clinically relevant. Most patients don't have hemolysis. So to be honest with you, if someone has a cold agglutinin positivity, unless they have hemolysis, I won't do anything. I mean, I don't think one has to go any further than ask whether that cold agglutinin has any clinical relevance to hemolysis.
But
so
even
I don't think it heralds thrombosis. Maybe Dr. Cuker can talk about that in his next talk. Hello, Adam. But anyhow, I don't have it. I think that these cold agglutinin tests are very, very commonly positive at low titer. They usually don't have a very high thermal amplitude. So in general, they are ignored. I'm not certain I carry much more. I would not evaluate them much further unless there's evidence of hemolysis.
Thank you.
Even with the history of COVID positivity.
I think that COVID positivity has no relevance here. If it does, we don't have any data.
Thank you.
Okay. Thank you.
Thank you. One last question from Dr. Ria.
Yeah, hi sir. I'm from Nagpur, and this part of the country we have a lot of sickle cell disease. We see a lot of patients with sickle cell who present with autoimmune hemolytic anemia. So would you recommend any other treatment which is different from that what we use in treating AIHA in these patients?
Well, I probably wouldn't recommend any different.
AIHA.
Yeah. Well,
Yes.
again, your experiences, I've not seen. I help run a large sickle cell center here. We don't see hemolysis. We don't see warm antibody hematology in many of our patients or any of our patients. So, if I saw it, I would treat it like somebody else. But I would worry that if these patients are heavily transfused from their sickle cell disease, that may be giving you some allo antibodies, not so much true auto antibodies. So I certainly want to ask your blood bankers to do a proper evaluation of the warm antibody to prove it's a true auto antibody, not simply an allo antibody.
No, we've got it done, sir. Some of them have allo antibodies as well, but what we see is around 15 to 20 of our patients with sickle have AIHA, and you're finding it difficult to treat these patients.
Again, they've pretty much already lost their spleens, as you're certainly aware. So it's not I don't have a simple solution. I think that, if I had to find the most benign medication in a non-COVID era, it would be to give them rituximab.
We have tried rituximab.
Yeah.
Some of them need long-term steroids. So one more question, a little off the topic. Hemolytic PNH, we normally don't have access to eculizumab. So apart from steroids, can we give these patients, can we offer them something else other than steroids?
Well, again, I'm an old kind of hematologist. I use steroids a lot in prior years for PNH patients. I also did splenectomy in PNH patients. So those are the options you got. I mean, they're typical. This is a typical hematology discussion. You got hydria, you've got splenectomy, you got corticosteroids and Rituxan. So, if you're on a desert island, those are the things you need to be a hematologist. But all kidding aside, I think right now that for PNH patients who can't get a complement inhibitor, that let me know this, because I have a global clinical study with complement inhibitors for PNH patients. If you've got a group in India with lots of PNH patients, I'm happy to put you in touch with my colleagues who can help you work with us on a clinical trial with an oral complement inhibitor.
I have 3 to 4 patients who are on steroids, hemolytic PNH, and not doing so well the more. So that would really be nice.
Dr. Agarwal, want to send me the names of PNH people who are interested in PNH, I can put you in touch with a company that would be love to talk to you about an oral PNH drug.
Thank you so much, sir.
All right, okay.
And excellent lecture.
We are running out of time, so we'll have to stop this here. There are 20 questions lying in the question box. I also wanted to ask something, but we really run out of time. So Dr. David Kuter, thank you so much. It has been wonderful. And the way the questions are pouring in, I think we will have to call you again, and I'm sure you will oblige us.
Well, I've enjoyed the last couple of times I've done this, so please, you've got my phone number, okay? But you're going to have a very good talk from my dear colleague, Dr. Cuker, next. So good luck, Adam. It's a tough audience, okay?
Thanks, David. I'm scared.
Take care, guys. Thanks. Nice seeing you all. Bye-bye.
Is Ashutosh here with us?
Yes, sir.
Yeah, please go ahead.
Thank you, sir. Thank you, Dr. Renu Saxena, for sharing your wisdom with us. Thank you, Dr. David Kuter, for the excellent lecture. It was interesting, informative, intriguing, enlightening, and much more. A big thanks to all the discussions for the elaborative learning you imparted to all of us. Thanks to all the participants for spending your valuable time on this Republic Day evening. Last but not the least, thanks to MICE Ideas for flawless execution of the program. At Adley, we stand committed to support all the academic programs. Not only that, we stand committed to support all the cancer patients to recuperate from the disease through our comprehensive product portfolio. Thank you so very much.
Thank you, Ashutosh, and good night to you. We move on to the second lecture of the day, and we already introduced Dr. Adam Cuker to you. He has already joined us. Just briefly to introduce him again, he's Section Chief, Benign Hematology, Associate Professor of Medicine and Pathology, Perelman School of Medicine, University of Pennsylvania. Over to you, sir.
Thank you so much, Dr. Agarwal. This is a real honor to speak with you today. I will share my screen and put my slides up. Give me just a moment. Can you see my slides? I put them in.
Yes.
Good. Okay. Very good. So hello, everybody. As Dr. Agarwal mentioned, my name is Adam Cuker. I'm a hematologist at the University of Pennsylvania in Philadelphia, and it's a real honor to speak with you today about my favorite disease, diagnosis and management of heparin-induced thrombocytopenia, or HIT, an update based on the American Society of Hematology guidelines. And so this slide shows my full disclosures. I serve as a consultant for Synergy. I receive authorship royalties from UpToDate. And my most important conflict is an intellectual one. I served as chair of the ASH guideline panel on HIT. And this is the manuscript that our guideline panel published in Blood Advances. And I just want to acknowledge my fellow panelists and co-authors who were, of course, instrumental in developing the recommendations that I will be presenting to you today. And so here are the learning objectives for my presentation. By the end, you should be able to describe a diagnostic algorithm for patients with suspected HIT, compare non-heparin anticoagulants for the treatment of acute HIT, and describe recommendations for managing anticoagulation for cardiac surgery in patients with a previous history of HIT. I want to begin with a very brief background to remind this audience that HIT is a profoundly hypercoagulable state. About 1/3 to 1/2 of patients with HIT will develop venous, arterial, and/or microvascular thrombosis. And unfractionated heparin carries about a 10-fold greater risk of HIT than low molecular weight heparin. I want to include just one slide on the mechanism of HIT. This is an oversimplified slide, but will drive home the point about why this is such a prothrombotic disorder. So here we have a cartoon of a platelet at rest. Platelets have alpha granules. Alpha granules have a number of molecules inside them, including PF4, or platelet factor 4. And platelet factor 4 exists in tetrameric form, and it is a positively charged chemokine that is released when platelets are activated. Platelets also have on their surface negatively charged glycosaminoglycans, or GAGs, and then on their surface they also have activating Fc gamma R2A receptors. So imagine that this platelet becomes activated, it undergoes shape change, and the contents of the alpha granules are released into the circulation. And the positively charged platelet factor 4 tetramers form electrostatic interactions with the negatively charged GAGs on the surface of the platelet. Now imagine that we give the patient heparin. Heparin, of course, is just an amalgam of negatively charged glycosaminoglycans. And in some instances, the heparin will displace the endogenous GAGs and form complexes with the positively charged platelet factor 4 on the surface of the platelets. And you can see some of these platelet factor 4 heparin complexes here. And when heparin binds to platelet factor 4, it causes the platelet factor 4 to undergo a conformational change that exposes a neoepitope. And some patients will make an antibody response against this neoepitope. And this antibody response is your typical antibody response. It starts with IgM antibodies and ultimately switches to IgG antibodies, typically around day 5 or so. And these IgG antibodies bind to the platelet factor 4 heparin complexes on the surface of the platelet. Now, not all of these IgG antibodies are pathogenic, but those that are have the unique ability to activate platelets. How do they do that? Well, the Fc portion of these antibodies binds to the activating Fc receptors of nearby platelets, causing those platelets to release their PF4 into circulation, and then you have more PF4 heparin complex formation, more antibody binding, and more activation of nearby platelets. And so what you essentially have in HIT is a vicious, unchecked cycle of platelet activation, which leads to a profoundly prothrombotic state as well as accelerated consumption of platelets resulting in thrombocytopenia. Now, again, I mentioned this is an oversimplified slide. These antibodies have the ability to activate not only platelets, but also monocytes, neutrophils, endothelial cells, all of which are probably important in the pathophysiology of HIT. So now I'd like to turn my attention to a case. This is the case of an 82-year-old woman. She has a past medical history of diabetes, hypertension, and congestive heart failure. And her home medications include metformin, ramipril, aspirin, and furosemide. She is admitted to an internal medicine ward with a heart failure exacerbation, secondary to poor compliance with diet and diuretics. She is treated in the hospital with intravenous furosemide and a nitroglycerin patch. On admission, she is also started on subcutaneous unfractionated heparin, 5,000 units every 12 hours for DVT prophylaxis. During the course of her admission, she has no fever. She is not started on any other new medications. Her blood pressure and heart rate are normal. She has no signs or symptoms of thrombosis, no bleeding or bruising. She's had no exposure to heparin in the 3 months prior to the current admission. And this is her platelet count trend. So her platelet count is normal at 200 on the day of admission. And you can see that it remains in that range through day 5. And then 6 days after admission, it drops to 150. And 7 days after admission, it drops to 67. I have a number of questions embedded in my presentation, and I understand that there isn't a mechanism for you to vote, but think about these questions in your head and what answer you would choose. So here's the first question. Considering this patient's progressive thrombocytopenia in the setting of heparin exposure, you are concerned about the possibility of HIT. Which of the following most accurately describes her clinical probability of HIT according to the ASH guidelines? Choice A, probably low probability given the overall clinical context. Choice B, probably high probability given the overall clinical context. Choice C, low probability based on the 4T score. Choice D, intermediate probability based on the 4T score. Or choice E, high probability based on the 4T score. And I will submit to you that the best answer to this question, according to the ASH guidelines, is choice E, high probability based on the 4T score. Here is the corresponding recommendation from the guidelines. In patients with suspected HIT, the panel recommends using the 4T score to estimate the probability of HIT rather than a Gestalt approach. There are a few important remarks that go along with this recommendation. First, missing or inaccurate information may lead to a faulty 4T score and inappropriate management. Second, and therefore every effort should be made to obtain accurate and complete information necessary to calculate the 4T score. If key information is missing, it may be prudent to err on the side of a higher 4T score. And of course, reassess the patient frequently. If there is a change in clinical picture, the 4T score should be recalculated. So many of you, I suspect, are familiar with the 4T score, but in case you are not, this is a scoring model used to estimate the clinical probability of HIT. And patients are evaluated across 4 domains: thrombocytopenia, the timing of the platelet count fall in relation to heparin exposure, the presence of thrombosis, and the likelihood of other causes of thrombocytopenia. And for each of these 4 domains, the patient can be given 0, 1, or 2 points. So the minimum 4T score is 0. The maximum 4T score is 8. A score of 3 or less is said to correspond to a low probability of HIT, 4 to 5 an intermediate probability, and 6 to 8 a high probability. So let's apply the 4T score to our patient. Her platelet count has fallen to 67, which represents a greater than 50% drop from her peak, which was over 200. And so she gets 2 points in the thrombocytopenia category. Her platelet count fall began on 6 days after starting heparin. That falls within the classical time frame for platelet count fall with HIT between days 5 and 14, and so she gets 2 points in the timing category. She has no apparent thrombosis, and so she gets 0 points in that category. But there are also no other clear causes of thrombocytopenia in this patient. And so she gets 2 points in the other causes of thrombocytopenia category. If we add up her score, 2 plus 2 plus 0 plus 2, she has a 4T score of 6, which puts her in the high probability category. But you know, when you think about these terms, low probability, intermediate probability, high probability, these are very qualitative terms. What do they mean numerically? Well, we set out to answer this question a number of years ago by conducting a systematic review and meta-analysis to define the diagnostic accuracy of the 4T score. And so in our meta-analysis, we included studies of patients with suspected HIT who had been evaluated by both the 4T score and a reference standard against which the 4T score could be measured, something like the serotonin release assay or the heparin-induced platelet activation assay. We identified 13 eligible studies, which collectively enrolled a little more than 3,000 patients. 56% of these patients had a low probability 4T score, 36% an intermediate probability score, and only 8% a high probability 4T score. And to cut right to the chase, this is what we found. The positive predictive value of a high probability 4T score was only 64%. So what that means is if we had 100 consecutive patients with suspected HIT and a high probability 4T score, only about 64% of them would have HIT and 36% wouldn't. So the lesson here, of course, is that even a high probability 4T score alone cannot diagnose HIT. You need laboratory testing to confirm the diagnosis. Not surprisingly, an intermediate probability 4T score has an even lower positive predictive value, only 14%. So if we lined up 100 consecutive patients with suspected HIT and an intermediate probability 4T score, about 14 of them would have HIT and 86 wouldn't. But from a clinical standpoint, the interpretation of an intermediate or high probability 4T score is that there is at least a fighting chance that the patient has HIT, and you have to take that chance seriously by treating the patient empirically as though they have HIT and ordering laboratory testing to clarify the diagnosis. On the other hand, we found that the true value of the 4T score is in its negative predictive value. The negative predictive value of a low probability 4T score was 99.8% in this study. So in other words, if you lined up 1,000 consecutive patients with suspected HIT and a low probability 4T score, 998 of them would not have HIT. And so the clinical interpretation here is that a low probability 4T score is really a robust means of ruling out HIT at the bedside. And you do not necessarily need to order HIT laboratory testing or treat such a patient as though they have HIT because the disease has been ruled out. So going back to our patient's 4T score indicates a high clinical probability for HIT with a 4T score of 6. What diagnostic tests would you recommend at this point to confirm or exclude the diagnosis of HIT? Choice A, none. The patient is high probability and the diagnosis is confirmed. Choice B, an immunoassay only, for example, a platelet factor 4 heparin ELISA. Choice C, a functional assay only, for example, a serotonin release assay. Or choice D, an immunoassay, and if the immunoassay is positive, then reflects to a functional assay. According to the ASH guidelines, the best answer to this question is choice D, immunoassay, and if positive, then perform the functional assay. So laboratory assays for HIT fall into two categories, immunoassays and functional assays. Immunoassays have the ability to detect the presence of anti-platelet factor 4 heparin antibodies, irrespective of whether those antibodies are able to activate platelets and cause HIT. And so these assays tend to be very sensitive, but not very specific because they fail to distinguish platelet activating pathogenic antibodies from the far more common non-platelet activating, non-pathogenic anti-PF4 antibodies. Functional assays, on the other hand, have the ability to detect only the subset of antibodies that are capable of activating platelets in a heparin-dependent manner. The problem with functional assays, though, like the SRA or the HIPAA, is that they are technically demanding and are therefore available at only a very limited number of reference laboratories around the world. So here is the ASH guideline panel's recommendation regarding laboratory testing. If there is an intermediate or high probability for T-score, the panel recommends an immunoassay. If the immunoassay is positive and a functional assay is available either locally or as a send-out test, the panel suggests a functional assay. There is a remark that comes along with this recommendation, and that is that the likelihood of hit increases with a higher 4T score and a higher ELISA optical density. So a very important point is that if your institution offers the anti-PF4 heparin ELISA, it's very important to report the numerical result, not just whether the test is positive or negative, because the more strongly positive the test result is, the more likely it is to represent a true positive. So piecing these recommendations together, we built a diagnostic algorithm. And the pieces that we've talked about so far are shown in colors. So if you suspect HIT, the recommended next step is to calculate the 4T score. If the patient has an intermediate or high clinical probability 4T score, you have to take the possibility of HIT seriously. And from a diagnostic perspective, that involves obtaining an immunoassay. If the immunoassay is negative, that essentially rules out HIT. But if the immunoassay is positive, then the recommendation is to obtain a functional assay if available to confirm the diagnosis of HIT. So back to our case, our patient's 4T score indicates a high probability of HIT, and you have sent off the HIT ELISA to your laboratory. The result is currently pending. Your patient has been receiving subcutaneous unfractionated heparin 5,000 units twice daily. What management strategy would you recommend while awaiting the ELISA result? Choice A, continue heparin as the diagnosis of HIT is not confirmed. Choice B, stop heparin, wait for the ELISA result. Choice C, stop heparin, start a non-heparin anticoagulant at prophylactic intensity. Choice D, stop heparin, start a non-heparin anticoagulant at therapeutic intensity. Or choice E, stop heparin and provide a platelet transfusion as the platelet count is only 67. And according to the ASH guidelines, the best answer to this question is choice D, stop heparin and start a non-heparin anticoagulant at therapeutic intensity. The idea here is, again, because of the 64% positive predictive value of a high probability 4T score, you have to take the possibility of HIT seriously and start treatment empirically while awaiting diagnostic lab test results. But, you know, I recognize that this is not an easy decision for many of us when we are on the hematology consult service, to treat or not to treat for HIT in a patient with suspected HIT. And the reason why this is not an easy decision is because we recognize that this is a high stakes decision. What do I mean by that? Well, we know that in patients with true HIT, for every day that we delay appropriate therapy, that is discontinuation of heparin and initiation of a non-heparin anticoagulant, there is about a 6% daily risk of thromboembolism, amputation, and death. So there is a very high cost to pay for missing or delaying treatment. On the other hand, treatment is not free. Some of these agents, non-heparin anticoagulants, are quite expensive, and they carry substantial bleeding risk, a risk of about 1% major bleeding per day. And we, with my colleague, Dr. Alison Pishko, have shown that patients who don't have HIT, who have suspected HIT but turn out to be thrombocytopenic for some other reason, actually have a higher risk of major bleeding when they are treated with non-heparin anticoagulants, probably because their thrombocytopenia is on account of some hemorrhagic diathesis rather than a prothrombotic diathesis like HIT. And so the cost of mistreating somebody who doesn't actually have HIT is also substantial. And that's why this is such a high stakes decision. So here is the ASH guideline panel's recommendations to help you in making this difficult decision. In patients with suspected HIT and a high probability for T-score, the panel recommends discontinuation of heparin and initiation of a non-heparin anticoagulant at therapeutic intensity. On the other hand, in patients with suspected HIT and an intermediate probability for T-score, who have a much lower likelihood of having true HIT, you still have to take the possibility seriously. So the panel recommends discontinuation of heparin, but the panel suggests initiation of a non-heparin anticoagulant at prophylactic intensity if the patient is judged to be at high bleeding risk, and at therapeutic intensity if the patient is not judged to be at increased bleeding risk. So there is very little evidence on this question of whether to use therapeutic versus prophylactic intensity anticoagulation in patients with suspected or confirmed HIT. There are in fact 3 small studies that have been done that have compared therapeutic versus prophylactic dosing with dinaproid, leparudin, or fondaparinux. In the dinaproid study, there was a 50% reduction in thrombosis among patients who received therapeutic versus prophylactic dosing. In these small leparudin and fondaparinux studies, there were no statistically significant differences in thrombotic outcomes. But nonetheless, the panel felt fairly convinced that prophylactic intensity anticoagulation was probably not sufficient for patients with true HIT, and therefore made a strong recommendation for therapeutic intensity anticoagulation, particularly in patients with a high probability for T-score. So one of the answer choices that I had there was the possibility of giving the patient a platelet transfusion. What is the role of platelet transfusion in patients with HIT? Well, the corresponding guideline panel recommendation is as follows. In patients with HIT who are at average bleeding risk, the panel suggests against routine platelet transfusion. There is a corresponding remark, and that is that platelet transfusion may be an option for patients with active bleeding or at high bleeding risk. Fundamentally, HIT is a prothrombotic disorder more so than a hemorrhagic one. And most patients with HIT will not have major bleeding issues and do not require certainly prophylactic platelet transfusions. And there has long been this theoretical concern that transfusion platelets in patients with HIT may add fuel to the fire and precipitate thrombosis. The evidence on this is more mixed. There have been several observational studies on the effects of platelet transfusion in patients with HIT. There was one large database study that suggested an increase in arterial, but not venous thrombotic events in patients with HIT who received platelet transfusion. But other small cohort studies have not suggested an increased risk in thrombosis. So I think the bottom line here is that platelet transfusions are not absolutely contraindicated in HIT, but they should really be reserved for situations where they need it. For example, again, patients with serious active bleeding, or maybe those who require a high bleeding risk urgent procedure. So back to our case, the laboratory test results are starting to come back. You ordered an ELISA, and the result is reported back that afternoon at an optical density of 1.8, so a strongly positive result. You ask your lab to send a sample to the local reference lab for a confirmatory serotonin release assay, and several days later, that result subsequently comes back positive. So you've now confirmed that the patient has HIT. Your patient continues to be clinically stable with no symptoms or signs of pulmonary embolism, deep vein thrombosis, or arterial thrombosis. So your patient has acute isolated HIT. That means HIT without clinically apparent thrombosis. The platelet count is currently 67. Which of the following non-heparin anticoagulants would be appropriate at this point? Choice A, argatroban. Choice B, rivaroxaban. Choice C, fondaparinux. Choice D, dinaproid. Or choice E, any of the above? Well, according to the ASH guidelines, the preferred answer to this question is actually E, any of the above. Lots of choices. Here is the corresponding recommendation from the guideline panel. In patients with acute HIT complicated by thrombosis, what we sometimes refer to as HITT, or acute HIT without thrombosis, isolated HIT, the panel recommends discontinuation of heparin and initiation of a non-heparin anticoagulant. And the panel suggests, as an option for non-heparin anticoagulant, argatroban, bivalirudin, dinaproid, fondaparinux, or a DOAC. It's interesting to look at how the HIT guidelines have evolved over time on this issue. In 2012, there were 2 HIT guidelines that were published. The American College of Chest Physicians issued recommendations for either argatroban or dinaproid. The British Committee for Standards in Hematology also recommended dinaproid and argatroban and added a suggestion for fondaparinux. But now here we are with the ASH guidelines, where we have new choices. In addition to argatroban, dinaproid, and fondaparinux, we have bivalirudin, and most notably, the addition of oral anticoagulants, direct oral anticoagulants. And so you might be wondering, well, what evidence was used to suggest that DOACs could be used to treat HIT? And so this table summarizes the evidence that was available to the ASH guideline panel at the time. 81 published cases of patients with acute HIT treated with DOACs, 49 treated with rivaroxaban, 21 with apixaban, 11 with dabigatran. You can see that a substantial fraction of these patients had HITT, that is HIT complicated by thrombosis. Now, some of these patients were treated with a parenteral agent first and then switched to a DOAC. This column shows you the percentage of patients that were treated with a DOAC first. But what I want to point out is that all of these patients were treated with a DOAC while they were still thrombocytopenic, so while they were still in what we call the acute phase of HIT. And the outcomes were very impressive in these 81 patients. Only 2 of them developed new or progressive thrombotic events while receiving a DOAC, and there were no major bleeds. Now, we have to take this evidence with some serious grains of salt. First of all, these are small numbers. Second of all, this evidence comes from case series and cohort studies. And so there is a major potential for selection bias. What do I mean by that? Well, imagine you were on the hematology consult service and you had 2 patients on your service with HIT. One was critically ill in the ICU with multi-organ failure, and the other one was clinically stable on the floor, approaching discharge. Which one would you be more likely to treat with a DOAC? Almost undoubtedly, you would be more likely to use a DOAC in the patient who's clinically stable. And so this may represent a particularly healthy subgroup of patients with HIT. You also might be more likely to publish your results if the patient did well. And so these data are subject to reporting bias. And we need more evidence in this area. Over time, more single-center case series and multi-center registries have been published, essentially supporting these very favorable outcomes. It would be great to have randomized control trials comparing DOACs with more conventional non-heparin anticoagulants in patients with HIT. But I think that those are very unlikely to happen, very, very hard to perform RCTs in HIT. And so we are going to need to rely on observational evidence to make this decision. But based on these very favorable outcomes that I showed you, despite the limitations in the evidence, the ASH guideline panel suggested DOACs as an option for the treatment of patients with acute HIT. Now, one of the things that the guideline panel did not do is prioritize or rank order these different non-heparin anticoagulants. So how do you decide which one to use in your patient? Well, that decision by the panel was intentional because we felt that the clinical context was so important in deciding which anticoagulant was best. So for example, in a patient who's critically ill, who's judged to be at increased bleeding risk, who is at high risk for needing urgent, unplanned invasive procedures, that sort of patient you would probably want to treat with argatroban or bivalirudin because they're shorter acting. On the other hand, if you have a clinically stable patient on the floor who has good kidney function, not at increased bleeding risk, maybe approaching discharge, that's the sort of patient where you might prefer fondaparinux or a DOAC because they're so much easier to use and they would facilitate transition to outpatient care. So let's go back to our case. So we decide to start our patient on rivaroxaban, 15 milligrams PO twice daily, and discontinue the heparin. Over the next 8 days, her platelet count gradually rises from 67 to 165, and there is no evidence of bleeding. So our patient has no symptoms of DVT or PE. Which of the following tests would you suggest to screen for asymptomatic venous thromboembolism? Choice A, there are no symptoms, so imaging is not indicated. Choice B, bilateral upper extremity ultrasound. Choice C, bilateral lower extremity ultrasound. Choice D, CT pulmonary angiogram. Or choice E, choices C and D. Well, according to the ASH guidelines, the preferred answer to this question is choice C, bilateral lower extremity ultrasound, even in this patient with no signs or symptoms. Here is the corresponding recommendation. In patients with acute isolated hits, remember that means hit with no clinically apparent thrombosis, the panel suggests bilateral lower extremity ultrasound to screen for asymptomatic proximal DVT. The panel also suggests upper extremity ultrasound in patients with an upper extremity central venous catheter in the limb with the catheter to screen for asymptomatic DVT. What is the basis for this recommendation? Well, there are observational studies that have shown that patients with acute isolated hit have a very high incidence of silent lower extremity DVT, ranging between 12 and 44%. And although we can't prove that these clots would become clinically important if left untreated, the panel decided that it made sense to treat even these silent proximal DVTs with longer anticoagulation. And so that's really the reason for detecting these silent clots, is that it may influence your decision about how long you anticoagulate the patient for. So back to our case, our patient has the ultrasound and indeed is found to have an occlusive left popliteal DVT. She continues rivaroxaban 15 milligrams twice daily for 3 weeks, then switches to rivaroxaban 20 milligrams daily for a total of 3 months. At 3 months, she returns to clinic. Her platelet count is normal at 205. She is at her baseline health status, and you ask her to stop the rivaroxaban. But now, 15 months later, this same patient returns to the hospital with another heart failure exacerbation. And at this time, she is found to have severe aortic stenosis with an aortic valve area of 0.6 square centimeters. She requires a valve replacement. Excuse me. So your patient with a history of HIT requires open heart surgery, and she will need intraoperative anticoagulation while she is on cardiopulmonary bypass. Her platelet count is normal. You repeat her HIT ELISA, and it is now negative with an optical density of 0.2. What would you suggest that your patient receive for intraoperative anticoagulation? Choice A, preoperative plasma exchange and intraoperative heparin. Choice B, intraoperative heparin only. Choice C, intraoperative heparin with an antiplatelet agent. Choice D, intraoperative bivalirudin only. Or choice E, intraoperative bivalirudin with an antiplatelet agent. Well, according to the ASH guidelines, the preferred answer to this question is intraoperative heparin only. To think about how to provide intraoperative anticoagulation in a patient with a history of HIT, it's first important to define the phase of HIT that the patient is in. And so HIT recovers in a sort of predictable way. The first phase is suspected HIT, right? Where the platelet count has gone down and we don't yet have our HIT laboratory test results. Acute HIT is the phase where we've confirmed the diagnosis with a positive functional assay and positive immunoassay, and the platelet count is decreased. After we stop heparin, the next thing that happens in the patient's recovery is that the platelet count normalizes. And that can take a variable amount of time in different patients, but about 90% of patients will have normalization of their platelet count within 10 days of stopping heparin. Now, once the platelet count normalizes, but the functional assay and immunoassay remain positive, we refer to that phase of HIT as subacute HIT A. The next thing to happen is that the functional assay becomes negative. And this typically becomes negative at a median of about 30 days after stopping heparin. So in subacute HIT B, this is the phase where the functional assay has become negative, but the immunoassay remains positive. Finally, after a median of about 85 days, the immunoassay becomes negative as well. And once the immunoassay becomes negative, we refer to the phase of HIT as remote HIT. And our patient, remember that this is now 15 months after her episode of HIT. Her immunoassay is now negative, and so she is now in the phase of remote HIT. And so we can use the phase of HIT to determine the appropriate strategy for intraoperative anticoagulation. In patients with subacute HIT B or remote HIT who require cardiovascular surgery, the panel suggests intraoperative anticoagulation with heparin rather than treatment with a non-heparin anticoagulant, plasma exchange in heparin, or heparin combined with an antiplatelet agent. And this is basically based on evidence that shows that it is safe to give intraoperative heparin in patients with a history of HIT as long as their functional assay has now become negative. There is an important remark that comes along with this recommendation, and that is that treatment with heparin must be limited to the intraoperative setting and scrupulously avoided before and after surgery. So this table summarizes the guideline panel's recommendations for cardiac surgery management in patients with a history of HIT. Again, if the patient has subacute HIT B or remote HIT, the recommendation is for intraoperative heparin during cardiac surgery. On the other hand, if the patient has acute HIT or subacute HIT A, where the functional assay is still positive, the recommendation is to delay surgery, if possible, until the functional assay becomes negative, and that is until the patient has moved on to subacute HIT B or remote HIT. But sometimes surgery can't be delayed. And if surgery cannot be delayed, the guideline panel offers 3 options. Use bivalirudin intraoperatively rather than heparin, or use heparin with plasma exchange to remove the anti-PF4 heparin antibodies, or use heparin with a potent antiplatelet agent. And the guideline panel did not offer a preference for one of these options over another, recognizing that there is no evidence directly comparing these different strategies to each other, and that the preferred option will likely be what your institution feels comfortable and familiar with. So I now quickly want to turn my attention to a second case. This is a case that is very similar to our first case. It's like, sort of like a patient living in a parallel universe with lots of similarities, but some subtle differences. Again, an 82-year-old woman with a past medical history of diabetes, hypertension, and congestive heart failure. Her home medications include metformin, ramipril, aspirin, and furosemide. And she too is admitted to an internal medicine morgue with a heart failure exacerbation secondary to poor compliance with diet and diuretics. Just like our first patient, she is treated with intravenous furosemide and a nitroglycerin patch. And on the day of admission, she started on subcutaneous heparin 5,000 units every 12 hours for DVT prophylaxis. Just like our first patient, during the course of her admission, she has no fever, no other new medications. Her blood pressure and heart rate are normal, no signs or symptoms of thrombosis, no bruising or bleeding. She's had no exposure to heparin in the 3 months prior to this admission, but her platelet count trend is a little different. On admission, her platelet count is normal at 200, and it remains in that range for the first couple days. Then 3 days later, it drops to 145, and it sort of stays in that range. And on day 7, it's 125. And so considering this patient's thrombocytopenia in the setting of heparin exposure, you are concerned about the possibility of HIT. Which of the following most accurately describes her clinical probability of HIT? Choice A, probably low probability given overall clinical context. Choice B, probably high probability given overall clinical context. Choice C, low probability based on the 4T score. Choice D, intermediate probability based on the 4T score. Or choice E, high probability based on the 4T score. Well, as we've already discussed, the ASH guideline panel recommends using the 4T score rather than a Gestalt approach for estimating the clinical probability of HIT. And if you were to calculate this 4T score, you would see that the preferred answer is low probability based on the 4T score. And indeed, we can apply the 4T score to our patient. Her platelet count nadir is 125, which represents a 30 to 50% fall from her peak platelet count. So she gets 1 point in the platelet count category. Her platelet count drop began on day 3. That is too soon to be characteristic of HIT, where the platelet count fall usually drops between days 5 and 14. And so she gets 0 points in the timing category. She has no apparent thrombosis, but on the other hand, there are no other clear causes of thrombocytopenia. And so if we add up her score, 1 plus 0 plus 0 plus 2, she ends up with a 4T score of 3, which puts her in the low probability category. And you will recall that a low probability 4T score has a negative predictive value of 99.8%. And so your patient's 4T score indicates a low clinical probability for HIT. What diagnostic tests would you recommend at this point to confirm or exclude a diagnosis of HIT? Choice A, none. The patient is low probability and HIT is highly unlikely. Choice B, an immunoassay only. Choice C, a functional assay only. Or choice D, an immunoassay, and if positive, then perform a functional assay. And according to the ASH guidelines, given the very high negative predictive value of a low probability 4T score, the best answer is choice A, none. The patient is low probability. HIT has basically been ruled out, and you should not order a HIT laboratory test because a positive result is much more likely to be false positive than true positive and potentially lead to inappropriate management. Here is the corresponding recommendation. Again, in patients with suspected HIT and a low probability 4T score, the panel recommends against HIT laboratory testing. There is an important remark that comes along with this recommendation, and that is that HIT laboratory testing may be appropriate for patients with a low probability 4T score if there is uncertainty about the score, for example, due to missing data, such as missing platelet counts. And so if we go back to our diagnostic algorithm, I showed you this algorithm before, but I focused on this side of the algorithm. Now we're going to focus on this side. Again, if the patient is suspected of possibly having HIT, a reasonable first step is to calculate the 4T score. If the 4T score is low probability, 3 points or less, you have basically ruled out HIT, and the guideline panel says, do not order HIT lab testing. The patient may be continued on heparin if indicated, and the patient does not require treatment with a non-heparin anticoagulant. So we go back to the resolution of our case. Given the patient's low clinical probability based on her 4T score, you elect not to send a HIT ELISA assay or functional assay. She continues to receive subcutaneous heparin. and her mild thrombocytopenia improves spontaneously. Here is her platelet count trend during the course of her admission. There are several additional topics in the HIT guideline that I didn't have time to cover today, but I'd be happy to discuss in the Q&A if desired. And these include platelet count monitoring patients receiving heparin, prophylactic IVC filter insertion in the setting of acute HIT, duration of non-heparin anticoagulant therapy in patients with acute isolated HIT, anticoagulant management for percutaneous coronary intervention in patients with acute HIT or a history of HIT, and finally anticoagulant therapy for HIT in patients undergoing renal replacement therapy. And so in summary, to go back to our objectives, our first objective was to describe a diagnostic algorithm for patients with suspected HIT. We talked about starting with the 4T score. If there's an intermediate or high probability 4T score, move on to an immunoassay, and if the immunoassay is positive, move on to a functional assay. On the other hand, if the 4T score is low probability, then you are done. No lab testing HIT has been ruled out. Our second objective was to compare non-heparin anticoagulants for the treatment of acute HIT. We talked about how both DOACs and parenteral options are all reasonable possible treatments for HIT, and that you might make your decision for treatment based on the clinical context. So a patient who is critically ill or at high bleeding risk, you might favor a parenteral agent like argatroban or bivalirudin. In stable patients with good renal function, you might prefer a longer acting and easier to use agent like a DOAC or fondaparinux. And finally, our third objective was to describe recommendations for managing anticoagulation for cardiac surgery in patients with a previous history of HIT. We talked about using HIT laboratory testing to define the phase of HIT. If the patient has subacute HIT B or remote HIT, the recommendation is to use intraoperative heparin. On the other hand, if they have acute HIT or subacute HIT A, where the functional assay is still positive, the recommendation is to delay surgery if at all possible. If it cannot be delayed, the recommendation is to use either bivalirudin or intraoperative heparin with plasma exchange or intraoperative heparin with a potent antiplatelet agent. And I'd like to just conclude by thanking my fellow guideline panelists, as well as Dr. Eric Sang from the University of Toronto, who helped in the development of this slide set. And I will stop sharing my screen and would be delighted to take any questions.
Thank you so much, Dr. Cuker. You made a subject which we often managed subjectively so objective. I think there is nothing left to guesswork. A lot of questions which people might have had in their minds have been already sorted out. But I'm sure there will be questions even now. First, if I can ask you, you left the IVC filter to questions. Could you tell us about that?
Yes, absolutely. So there's not a lot of evidence in this area, but there is a little bit. And the evidence suggests that patients who have acute HIT and have an IVC filter in place have an extremely high incidence of filter thrombosis. And so, except in extraordinary circumstances, the panel made a strong recommendation not to place prophylactic IVC filters in patients with HIT. The best way, these patients need anticoagulation, and filters only serve as a nidus for thrombosis.
Right. And the last one, which you mentioned about patients on renal replacement therapy.
Yes. So this is a complicated issue because it depends on the phase of HIT. But, you know, most patients on hemodialysis, for example, will do very well with sodium citrate. So if the patient has a remote history of HIT and they no longer need anticoagulation on account of having had HIT, but they need some sort of anticoagulant to prevent thrombosis of the dialysis circuit when they have hemodialysis, the panel recommended using sodium citrate for that purpose rather than re-exposing the patient to heparin.
Thank you. Dr. Kunkar, your question.
That was an excellent talk, Dr. Adam.
Thank you very much.
I just want to ask, suppose there is death of the patient, what is the major cause of death of patient in case of HIT?
Yes, thank you for that question. The mortality rate with HIT is not trivial. It's depending on the studies you see, something like 10, 15%. So this is a very, very mortal disease. The most common cause of death is thrombotic death, myocardial infarction, stroke, fatal pulmonary embolism. But certainly there are also patients, I have seen patients who have died of bleeding, probably as a complication of their non-heparin anticoagulant therapy.
One more, sir.
Yes.
Out of the 4 T's, the 4th T is likelihood of any other cause of thrombocytopenia. How it is?
Yeah, it's a great point you make. It's a very subjective criterion, isn't it? Because when we think about other causes of thrombocytopenia, so I think about does the patient have an infection? Has the patient been exposed to other medications that could cause thrombocytopenia? Does the patient have DIC? Has the patient had, let's say, recent cardiopulmonary bypass in the last day or two? But you and I might make different judgments about the likelihood. Is there a possible other cause? Is there a definite other cause? So there's a lot of subjectivity and what we call inter-rater variability in that criterion. And one of the ways we've tried to address this is by my team developed a different scoring system for HIT called the HEP score, which stands for HIT Expert Probability Score. And that score has more items, and it sort of explicitly itemizes these different potential causes for thrombocytopenia. And it leads to better inter-rater agreement. But when we compared it with the 4T score, the ultimate diagnostic accuracy was not different. But I think your point is well taken, that a limitation of the 4T score is the subjectivity surrounding that 4th criterion.
Yes, thank you.
Thank you. One question from the audience. If a patient has been exposed earlier to heparin, how early can the platelet count drop in HIT?
Yeah, thank you for that question. And I'm glad that it was asked, because I didn't have a chance to mention this during my presentation. So during my presentation, I focused on typical HIT. And in typical HIT, the timing is such that the platelet count typically falls between 5 and 14 days after initial heparin exposure. And the reason for that delay is because it takes time for patients to make IgG antibodies against the PF4 heparin complexes. But what about if a patient had recent heparin exposure, let's say within the last 30 days, and they already have pre-existing anti-PF4 heparin antibodies in circulation? That patient is at risk for something called rapid onset HIT. And so if they were to be re-exposed to heparin, we would expect that the platelet count would drop immediately. And so in rapid onset HIT, the patient has had recent heparin exposure almost always within the last 30 days, and their platelet count falls within 24 hours after heparin re-exposure.
Thank you. Samir, your question.
Dr. Adam, what is the role of IVIG in the treatment of HIT? For example, in vaccine-induced thrombocytopenia with thrombosis, VITT, there is a role. It could to improve the platelet count, and well, theoretically, would it also block the Fc gamma receptors in the platelets and prevent further activation of platelets?
Yeah, it's a terrific and very timely question. Because there has been some momentum building, and you see this in the literature with various Cates reports published over maybe the last 3 or 4 years, showing good outcomes in patients with refractory HIT who received IVIG. And the mechanism is probably just as you suggest, that there is competition for the Fc receptors on the surface of the platelets. And so it's basically blocking activation of platelets by these PF4 heparin immune complexes. And so I have used IVIG in a couple cases myself. I certainly don't use it in everyone with HIT, but I had, for example, and maybe some of you have experienced this too, patients with very prolonged severe thrombocytopenia, where we stopped their heparin, we started treating them with a non-heparin anticoagulant, and even 1 week, 2 weeks later, their platelet count is still like 30,000, and we don't. It's preventing them from really being able to fully recover and be discharged from the hospital. And I have given IVIG to a couple patients in this situation with remarkable improvements in their platelet count. I don't think we're at a place yet where we use IVIG routinely in all patients with HIT. I think we need more evidence on that, but I think it is an important tool that we have for these refractory patients.
Thank you.
Thank you. One more question from the audience. Is there a particular low platelet count below which you'll be concerned about starting non-heparin anticoagulants?
Yes, thank you for that question. So the answer is yes and no. Occasionally we will, so I should say the median nadir platelet count in HIT is about 60. And so most patients with HIT do not have severe thrombocytopenia. But we do occasionally see cases where the patients have very low platelet counts. And this is actually often in really severe cases of HIT that are accompanied by DIC, where we see platelet counts below 20, sometimes below 10. And I would be lying if I told you that I don't have a little bit of fear about starting non-heparin anticoagulants in patients with platelet counts that are so low. But on the other hand, when I think about it pathophysiologically, these patients need the anticoagulation more than anybody. There's actually evidence that the more severe the thrombocytopenia, the higher the thrombotic risk in HIT. And again, this probably has something to do with DIC. And so these patients, despite our fears, really need anticoagulation. I think that based on the last question, one could consider giving IVIG along with the anticoagulation to try to accelerate platelet count recovery, but it would be dangerous to withhold anticoagulation in such patients because they're at such profoundly high thrombotic risk.
Thank you. Mukul?
Thank you, Dr. Adam, for an excellent talk. My question is, first is with respect to low molecular weight heparins. So does the 4T score hold a similar significance for the low molecular weight heparins as well? Because day in, day out, we treat patients with DVT and PE and we don't see it often. And the second will be, what is the role of immunosuppression, say with steroids, rituximab, or even plasmapheresis in the therapeutic?
Yeah, thank you for those questions. The first question is about low molecular weight heparin, and you're absolutely right that low molecular weight heparin carries a substantially lower risk of HIT than unfractionated heparin, about 10-fold lower. It does happen, and it presents the same way with a platelet count fall, typically beginning 5 to 14 days after initiation, and with a strong propensity for thrombosis. So we still use the same criteria when considering whether the patient has HIT. So the 4T score is the same right now, whether the patient had unfractionated or low molecular weight heparin exposure. That said, I will tell you that I'm aware of some work that is still in the investigational phase. There is a hematologist in Switzerland named Michael Nagler, and he is developing a new scoring system for HIT. And one of the criteria is whether the patient had unfractionated or low molecular weight heparin exposure. And I've seen some very promising evidence from his scoring system, unpublished as yet, that suggests that it may perform better than the 4T score. So stay tuned, and your question may turn out to be quite prescient.
What about the immunosuppression?
Yes, thank you. So, there is no role for immunosuppression in the treatment of HIT that we know of. And, it isn't something that's been well studied. I believe that there are some old studies with corticosteroids that don't seem to suggest any effectiveness. But I think that, HIT is such an acute and explosive disease that it may be that even if you could give immunosuppression to, let's say, shut down production of the antibodies, the antiplatelet factor 4 heparin antibodies, by the time you've done that, it's already too late. These IgG antibodies have a half-life of 3 weeks. And so if you start shutting down antibody production, it may be too late. The patient's already been in the window of high risk for thrombosis.
Okay, a connected question by one of the audience is, can we use LMW heparin in prophylactic dose for treating it?
Yes, thank you for that question. So no, if the patient has HIT, you should not use any form of heparin, neither unfractionated nor low molecular weight, because most of these HIT antibodies can cross-react with complexes of platelet factor 4 and low molecular weight heparin.
Thank you. Another question is whether you will give aspirin together with rivaroxaban for treating HIT.
Yes, thank you for that question. There's certainly a rationale for using antiplatelet agents, isn't there? Since this is, as I showed, a disease of unchecked platelet activation. There were, again, old studies, not very high quality, that suggested that antiplatelet agents were not especially helpful in this disease. And so anticoagulation seems to be more effective than antiplatelet agents. So typically we would not use antiplatelet agents to treat HIT. The exception would be, as we discussed, patients who have either acute HIT or subacute HIT A and require cardiovascular surgery. One of the options for these patients, for which there is some supporting evidence, is to use intraoperative heparin and a potent antiplatelet agent to try to get them through surgery and prevent thrombosis of the circuit.
Thank you. Another question is, once you have started non-heparin anticoagulants, if the platelet count is very low, can you give platelet transfusion?
Yes, thank you for that question. As I mentioned, we try not to use platelet transfusion when we can in HIT because there is a theoretical risk and some evidence that platelet transfusions may precipitate thrombosis in patients with HIT. And furthermore, HIT again tends not to be a hemorrhagic disorder. And so prophylactic platelet transfusions are not typically used. I would not generally use platelet transfusions in somebody with HIT to permit safe use of anticoagulation. I think that even in patients with HIT, even those with low platelet counts, generally tend to tolerate anticoagulation quite well. I would, however, consider platelet transfusions in somebody who was actively bleeding, or maybe somebody who needed an emergency procedure that could not be delayed, and we felt that the platelet count needed to be higher to be able to perform the procedure safely.
Thank you. Dr. Cecil, your question.
So in case of this high-stake decisions, and sometimes that's quite a difficult decision to take in the ICU setting, would TEG be useful to tilt your balance this way or that way?
Yeah, thanks for that question. I personally, I've seen some articles in the literature about the use of TEG in patients with HIT, and not surprisingly, they do have the expected hypercoagulable signatures. But I've not seen, nor is it clear to me, how one might use that information to guide management. That could be tested in a clinical trial, but it isn't obvious to me how that would be done. Do you have a thought in mind about how you might use
because we don't have access to either the functional assay or the immunoassay, and so I was just thinking, whether we can use TEG to be able to either treat or monitor with whatever decisions we make, depending on the guidelines.
Yeah,
be able to more strongly say that this is worthwhile giving anticoagulation a little more vigorously therapeutic versus prophylactic, to use TEG to make that decision, to use prophylactic doses or therapeutic doses.
Yeah, I mean, I think it's a fascinating question, and I have great admiration for you, because you have to do the best you can with the resources that you have available, and I think that that's a question that's worth studying. To my knowledge, it has not been studied, but I think it's a worthwhile question.
Okay.
Dr. Amrita, your question.
Thank you, sir. First of all, it was a very wonderful talk, and we have really updated our knowledge. We are doing this test almost daily basis, and my senior colleague and head of the department, Dr. Jyoti Kotwal, has really, encouraged this test and established it in the, in our hospital, which is a premier hospital in Delhi. So my question is to Dr. Adam is that, like, we get many cases of the suspected hit where, truly speaking, we are sometimes not really sure if the clinician is sure of their T-score, or it's just, they just want us to do the test and rule it out. So we do this immunoassay using the gel card, which many a times is clear-cut positive, but sometimes it gives us suspicious results of borderline positive. That is like, when we compare it with the positive and negative control, we ourselves are not sure, but we cannot make it negative unless it's really clear. It gives us pinkish coloration. So in such cases, what do you say? Like, should we really rely on the T-score and go ahead, or suggest a PAT, functional assay, which we are doing very routinely, or we should again discuss the case and wait for it, and only then we should get it, we should proceed for PAT? So what is your suggestion on this particular type of situation where we are getting, borderline positivity?
Yeah, thank you. And may I just clarify, I want to make sure I understand which lab tests you have access to. So it sounds like you have the particle gel immunoassay.
Yes, particle gel.
And do you have, did you say you have a functional assay also?
Yes, we are doing it flow cyte, the platelet aggregation using the PAT, the platelet aggregation, using the heparin in different doses.
Okay, and do you have the ELISA also, or
no, we are not doing ELISA for that.
Okay. Yeah, so I personally don't have experience with the particle gel immunoassay. It's not actually approved for use in the United States, but is quite a good test with I think comparable performance to the ELISA, and has the advantage of being a rapid test, as you know. So you'll get the results much more quickly than I do. I think and I don't know if I have easy answers to your questions. I guess one thing I'd say is I would urge doing the 4T score before you do the particle gel immunoassay. It's such an easy test to do. It's very tempting to do it on everybody, but the problem is that there are false positive results, and so if it's applied to patients in whom it's not appropriate, the results can lead to misdiagnosis and inappropriate management decisions. So I do firmly stand by the idea of calculating the 4T score first and limiting the assay to only those patients who have an intermediate or high probability 4T score, or if you have maybe uncertainty about the low probability 4T score. And if the assay is equivocal, then I think I would probably be inclined, if somebody has an intermediate or high probability 4T score and an ambiguous particle gel immunoassay, I would probably be inclined to treat that patient empirically as though they have HIT, and order the functional assay to try to clarify the true diagnosis.
Okay, thank you so much.
Perfect examples of the challenging real life situations that we all face.
Yes, thank you so much.
Thank you. Another question from the audience is that if you have a disorder which is prothrombotic, like say COVID-19 infection, and you are giving unfractionated or low molecular weight heparin, now if this patient develops thrombosis, and is it due to the basic disease, or it is due to, or it is HIT? How easy or difficult it is to differentiate?
Yeah, thank you for the question. Of course, just like you in India, we've had so many patients in the hospital with COVID-19 develop thrombosis. and the vast majority of those patients do not have HIT. In fact, I think that there's some pretty good evidence now that while HIT can certainly occur in patients with COVID-19, it doesn't appear to be any more likely than in non-COVID-19 patients. And so you should always consider the possibility of HIT in somebody who develops thrombosis while receiving heparin. And I would evaluate such patients just the same whether they have COVID-19 or not. But the vast majority of COVID-19 patients with thrombosis do not have thrombosis because of HIT.
Thank you. One question is about the dose of IV gamma globulin in this situation.
Yeah. So again, this is something that has not been extremely well studied, and there are not studies comparing different doses. I have used sort of the typical ITP dosing, which for me is usually 1 gram per kilogram once a day, daily for 2 days. That's my usual dosing.
Right. One question is related to heparin, which is given for flushing the central venous catheter. These patients develop thrombocytopenia. Should you investigate them for HIT?
Yes, you should. This is very rare, but there are case reports of patients developing HIT where their only heparin exposure was heparin flushes. And so it is something that needs to be on your differential if the criteria are right. And so you can apply the 4T score to these patients just as you would somebody who got heparin subcutaneously or intravenously.
Right. Subha Prakash, your question.
Sir, I have a very basic question. So in the bedside, when you are convinced that it is acute HIT and you want to give therapeutic anticoagulation, do you really look at the platelet count, or you just use the therapeutic dose of anticoagulation, whether the platelet count is 20, 30, whatever you?
Yes. So I'm going to make sure I understand the question. I think what this gets to is that according to the recommendations that we reviewed, if a patient has a high probability 4T score, then you should use therapeutic intensity anticoagulation. If they have an intermediate probability 4T score and you judge them to be at high bleeding risk, you can use prophylactic intensity anticoagulation. Whereas if you judge them to be not at increased bleeding risk, you can use therapeutic intensity anticoagulation. And I think what your question is getting at is, what are the criteria that we use to judge bleeding risk? And I think it's a great question. I think platelet count is one such criterion. Somebody with a very low platelet count and an intermediate probability 4T score, that might be something that tips me toward worrying about bleeding risk. I'm also thinking about patients who've had very recent, let's say, cardiac surgery. Maybe they have an open chest. These are the sorts of patients also where I would be worried about high bleeding risk and might be inclined to use a lower intensity non-heparin anticoagulant if I could. But I should also clarify that if and when the diagnosis of HIT is confirmed, then the panel recommends that the patient should get therapeutic intensity anticoagulation.
Thank you.
Thank you. Last question is, how do you rate fondaparinux in the treatment? It's like a heparin.
Yes, thank you. So I have used fondaparinux quite a bit to treat HIT. The sorts of patients that I would favor the use of fondaparinux or a DOAC in are clinically stable patients with acceptable renal function, so a creatinine clearance better than 30 mils per minute. And in particular, patients who are perhaps approaching discharge from the hospital, because a drug like fondaparinux is so easy to use and can be easily transitioned to the outpatient setting. I would not use fondaparinux in a critically ill patient, in a patient with poor renal function, because of the longer half-life and potentially, therefore, a higher bleeding risk.
Thank you. No more questions from the audience. Faculty here, you have any questions? None. So in that case, Dr. Adam Cuker, extremely grateful to you.
Thank you so much. This was wonderful.
It was a great way of teaching, and it sort of put everything, all the doubtful questions were taken away. Fantastic. You are a great teacher, and you spared so much time for us. We are grateful to you, and probably will bother you in future as well.
Oh, it would never be a bother. Thank you for the kind invitation, and good luck with the rest of the meeting.
Bye-bye.
Okay.
Thank you. And good night to everybody from India. Bye-bye.